primary eye care centers. I have no financial disclosures. So as we know that the incidence of diabetes is increasing worldwide with India in the lead, and it is estimated that India would have 6.08 million people with diabetic retinopathy by 2030. This necessitates screening for diabetic retinopathy. The screening can be done by ophthalmologist by direct examination, either in hospitals or in remote camp settings, or by imaging. This imaging can be done by traditional tabletop fundus cameras or by smartphone-based fundus cameras, and the images can be graded by teleophthalmology by ophthalmologist or by an AI-based system. So here we present our findings of an offline, on-the-edge AI which can be used anywhere, any place by anyone, minimally trained personnel without the requirement for an internet connection or electricity. A short video about how the fundus camera works.
So timer, you have not set the timer.
So this Remedio fundus-based, smartphone-based fundus camera takes images of the retina, and these images are then uploaded to the software, the AI-based software present on the same fundus camera, and it provides an analysis of the DR as a referable or non-referable DR within 10 seconds. So with this background, to screen a tool for, validate a tool for quick screening of diabetic retinopathy and negate the need for training resources, we went about to assess the performance of an automated screening tool for referable diabetic retinopathy using artificial intelligence deployed offline on a smartphone-based fundus camera at primary eye care centers. Our secondary outcome measures were to assess the positive and the negative predictive value for referable diabetic retinopathy, the sensitivity for referable or sight-threatening diabetic retinopathy, and sensitivity specificity for any grade of DR. So this retrospective study was carried out between December 21 to May 22. Images were captured by minimally trained nurses, 2 images disc and macula centered, and these images were then run through the AI system and were graded as referable or non-referable. The same images were shown via teleophthalmology to the primary eye care center graders, who also graded the images accordingly. So out of the 271 patients that we analyzed, the primary eye care center graders referred 47 patients as referable DR, of which 45 were identified by the AI system and 2 were missed. This gave us a sensitivity of 95.74% and a specificity of 75.89%. This was because of false positives which were mild NVDRs that were flagged by the AI system. Here is a representation of some of the images, the true positive, false negative, and true negative that were detected during this screening program. Of the 50 patients that were referred to the base hospital, the AI agreed with the expert clinical diagnosis in 100% of cases, whereas the diagnosis of the primary eye care center graders was agreeable of only to 75%. And as I mentioned, the AI had some false positives, while the doctors had 5 false positives and 6 false negatives. So this AI has demonstrated high degree of sensitivity and specificity in diagnosis in previous studies. In a community-based study, it showed for RDR, it showed 100% sensitivity and a specificity of 88%. The same AI was also evaluated for images captured on a standard tabletop fundus camera, and there also it showed a high degree of sensitivity of 98.3% and a specificity of 83.7 for referable diabetic retinopathy. So most AI systems are evaluated on well-curated retrospective databases, and these may not be representative of what we actually see in real-life imaging. And here we show real-world evidence of data collected from 12 primary eye care centers, and this also compares it against 2 benchmarks, that is the teleophthalmology grading, which is what would happen in the absence of an AI, and clinical evaluation by retina specialist. So the AI demonstrates higher sensitivity compared to the doctors who are grading it. But this is at the cost of slight over-referral of mild diabetic retinopathy cases, which can be acceptable from a public health perspective. So to conclude, we have a non-mydriatic smartphone-based fundus camera, which requires minimal training to use. We have an offline AI, which is integrated on the same smartphone, does not require any network connection, is easy to use in remote areas, with a high degree of sensitivity, making it a robust, fast, easy to use triaging tool, and this makes DR screening accessible, affordable, and scalable in communities with limited resources. Thank you.
Thank you, ma'am. It was a wonderful presentation. Only one question, because no discussion that was needed. What happens if it is only AI related, expert's opinion you want to take? apart from AI?
So the AI will is only a screening tool. So you take it to the camp setting where you are screening many diabetic because a doctor can't go there. The technician, any minimally trained person takes photos, runs it through
No,
the
I
AI,
got it.
and it just tells you which patients are referable. That means who are the ones that need to go to a doctor immediately,
Okay.
and who can be just observed and followed up at the campsite itself.
Thank you.
You said it to be the smartphone, any specific, because every phone has got a different variety of the pixel resolution of the camera. So for that,
This is
what
compatible.
phone you have used?
This is the Remedio smartphone-based fundus camera, sir, that they have.
So
They provide the phone with it,
phone
usually
also.
an iPhone,
That's
sir.
it.
With it.
Okay, that's it.
Thank you. Now, Dr.
Thank you.
Abdul Kamal, please. Are you ready? Okay. Dr. Mahesh. Yeah, please. Thank you. Then Dr. Sheila Devi Sethu, though you are present, you are non-ratified member. Non-ratified means you are member, but your membership will be confirmed in the GPM, and then you will be ratified. So you will not be given marks. Okay, sir, you can start.
Thank you, sir. Good morning, everyone. My talk is on critical evaluation of knowledge, attitude, and regarding consents in medical practice among ophthalmologists. In fact, way back in 1914, Justice Cardoso, in his landmark judgment, said every human being has the right to choose the treatment to be done with his or her own body, and any violation without consent is liable for damages. And any medical professional can face civil, criminal, and medical counsel, and now human rights problems also. So these are few things that we should all be worried. So the role of consent is important in this, and there are different types of consent. In UK, it is valid and real consent, which does not include all the details, while in US, it is informed consent, which includes everything, including risk associated with no treatment also. In the landmark Samira Kohli versus Prabha Manchanda case in 2008, Supreme Court has set the guidelines for true and legitimate consent to be followed in India. And medical litigations, a big study from South Korea said 50% of litigations are due to lack of consent. So objective of the study was to analyze the knowledge and attitude and practice pattern regarding consents in ophthalmologists. So it was an online survey done last year, and it was a questionnaire with 4 parts, 51 questions. It was validated by a pilot study, and it was asked to send to members of Kerala State and All India Society. The general demographics mostly were females, as we all know, mostly general ophthalmologists, mostly surgeons, very few are only medical ophthalmologists, and these are some of the salient features. And out of 180, 16 already had a case against them in one of these fora. So knowledge, regarding the knowledge part, 92.5% were knowledgeable, in the sense they know all the criminal, civil liability, etc. 82.8% knew elements of the consent, and when it is not needed. And there was a problem, blanket consent has no legal validity. This was known by only 62.4%. Surprisingly, 1/3 of the doctors thought it is okay in some places like camps, which is wrong. Other practice done by many of our doctors. Anesthesia consent should be different from the ophthalmology, our surgery consent, especially in general anesthesia, but only 50% of our doctors practice that. The consent is not different. So another question for cataract surgery, what consent they used? Many of the doctors, 3/4 of the doctors, 74.1% took that was more in institute practice regarding consent, which is acceptable, which is understandable. So in conclusion, more training about medical law and ethics are needed in the curriculum of medical students, and specific training, especially CME credits, has to be given and mandatory to all the doctors. And the AOS has come up with standard consent in ophthalmic procedures, which should be used by all of us. We are already judges of our own rights. Now what is remaining is to become lawyers so as to defend it. Thanks for the kind attention. Thank you.
That was a nice presentation, and I have to say that Dr. Marath.
Everything is formulated in that particular format. And the languages, various languages in India, like in Maharashtra, we have translated those in Marathi, and that booklet is available even online. Maybe in Kerala you must have tried
Yes,
the same thing.
Malayalam.
And those language specific consents are very useful. You just go through that and try to use that. And that's very important to go for consent for each and every procedure. Though you are very good in your scientific knowledge, in your training, in your operative procedures, but if the consent is not properly taken, probably medical legal litigation may be there. So please avoid paid presentations. Thank you.
Thank you.
Sir.
Thank you very much.
The timer is not set here. It is not seen. So not. So please.
We don't have any financial disclosure in this, and we like to acknowledge the REACH Research Group members for their contribution, and Katha Fund for Development and Santon for their funding. As we all know, uncorrected refractive error is a major cause of visual impairment and blindness, and it has a huge effect on the children's literacy levels and overall well-being of the children. There are many longitudinal studies in the globe, and they report a wide range of compliance to spectacles, which ranges from 10 to 79%, whereas in India it was estimated about 30%. Many reasons were reported for the non-adherence. And refractive error among children, the REACH program is the main flagship program for Orbis India, and it started in 2016 and it's still continuing, and we have served more than 2 million school children in the past. The present study reports on the adherence with spectacles prescribed among children participating in the REACH program. This study was conducted in 6 locations across 5 states in the country, covering 15 districts. And REACH followed a standard protocol across all the participating organizations. It includes the primary screening and detailed evaluation is conducted in the school campus, and spectacles booking and delivery also happen in the schools. And the choice of spectacles were given to the children before the delivery is made, and the compliance visit was done in the schools after 3 months. And those who require further services were referred to the hospitals, and both compliance to hospital visits as well as the spectacle delivery was assessed at the school campus. We also followed up the children on an annual basis. The compliance assessment was done unannounced in the school campus after 3 months from the spectacle delivery date. It is assessed by a trained team of people, and the assessment is the presence of spectacles on the face of their child. And we used a structured questionnaire independently to record the reasons for wear and non-wear among the children in the local language. So overall we have covered 2,100 schools. Majority of them are from rural areas, and 67% of them were government funded schools. Over 32,000 children were prescribed in this 2,100 schools, of which 93% of them were available for the assessment on this compliance day. We found 66% of them wearing these prescribed spectacles, which is quite high compared to the previous reports from the country. And interestingly, the first time users were more significantly wearing compared to the existing wearers. And we didn't find any significant difference between the boys and girls in the adherence levels. Although there is a change in the adherence, the younger group were wearing mostly the spectacles prescribed compared to the higher age group, which is 15 to 18 years. And a significant higher percentage of children were wearing in rural areas and privately funded schools than the government funded schools. Children with myopia and astigmatism were more likely to wear spectacles compared to other refractive errors. We also looked at the reasons for spectacle wear, and the major reason reported includes clear vision by around 37% of the children, and the second major reason is looking good. So these are the major reasons for spectacle wear. And the reasons for not wearing spectacles were also obtained, and the main reason was 8%. They didn't like the spectacles, and around 3 to 4% have lost or broken their spectacles. So to conclude, we have this study reported a higher level of adherence among the school-going population, but it also covered quite a large number of children from different types of schools in urban and rural areas. And we used non-adherence. This is something new rather than non-compliance, to avoid suggestion that children are being forced or compelled to obey an instruction. And so the main reason for not wearing spectacles was dislike spectacles, even though the child had the choice to choose their own frames. So this may not capture the real reason for disliking them. So we need more exploratory research to understand why children dislike the spectacles. And there are many research is being carried out as part of REACH program to investigate approaches, how do we improve more adherence among school children, including strategies such as communications with teachers and parents. And thank you for your attention. These are the references. Any questions?
That's good, but then you had one slide was showing that the parents disallowed the usage of the spectacles.
Yes.
Any reason that you could reach the cause?
Actually, no, this was reported by the children, so we really don't know what exactly the reasons behind it. So we are working on, exploring what could be the probable reasons from the parents. But some girls' parents, they said, they don't want their child to wear it when they are going out. They are happy if they are wearing it while they are studying inside the home or in the schools.
But
So
you
these-
did contact the parents.
So a couple of parents, but not in a research mode, I would say. But we did talk to a couple of parents why they were not interested in allowing their child to wear spectacles.
Okay, that's fine.
Thank you.
Thank you.
So once you get ratified, try to continue the same. Good. Now the next presenter is Dr. Vidhi Shani. And after that, Dr. Vasumurthy.
Good morning, one and all. I'll be speaking on knowledge, attitude, practice pattern, and willingness for eye donation among tribal population in northern Odisha. According to WHO, there are 45 million blind people worldwide, of which 5% are due to corneal blindness, who all require corneal transplantation. It is estimated that 2,77,000 donor tissues are needed every year to fulfill the gap between demand and supply of corneal tissue. Since eye donation is purely voluntary, therefore the family's knowledge and belief significantly impact consent for the same. Therefore, it's important to make the mass population aware of their social responsibility towards the corneal blind. So the purpose of our study was to assess the knowledge, attitude and willingness for eye donation among the patients and relatives attending the outpatient department of ophthalmology in a government medical college in tribal part of the country. The survey was conducted between March 2020 to December 2020, which included 984 patients and their relatives attending the ophthalmology OPD. Patients, people below 18 years of age, those with cognitive impairment and relatives of patients who were in need of corneas for transplantation were excluded from the study. There was a structured questionnaire which was used to elicit response, and interviewers were trained to explain the questions in local language and get the responses noted. So there were around 20 questions with multiple choice options, out of which we can make out if the patient was knowing or not knowing, and that included the demographics, the knowledge about donation, their attitude, and whether they were willing to donate or not. So age and gender, there was no significant preponderance. Education wise, people were mostly literate, and the location, mostly the people belonged from the tribal areas. Mostly people belonged to Hindu religion. Coming to results on knowledge about cornea donation, the knowledge was not good on any aspect, but it was specifically very low for regarding who all can donate the eyes. It was around 33%. Then cornea retrieval time, how much time it takes, most of them did not know, and that would significantly impact on the consent for eye donation. People will think it will take some 1 or 2 hours, and they will say a no to it. Then for eye donation, whom to contact, knowledge about the nearest eye bank, that was only 22%. Regarding the modes of awareness, it was almost equally through newspaper, TV, internet, radio, through posters, pamphlets, friends, relatives, neighbors, various ways. Coming to results on willingness to donate. So the willingness was more among the younger generation people and the more literate ones, and among the people who were coming from urban locality, though the majority of population in our study were from tribal areas. So 51.8% participants were willing to donate eyes, while 48% were not willing. The most common reason being insufficient information, followed by family members may not permit, and very few were of religious disbeliefs, like they may be born born blind the next birth and such, or some facial disfigurement will happen, and all these reasons. Coming to discussion, in our study, 65 patient participants were aware about eye donation after death, which is lower in comparison to various other studies from other parts of the country. In our study, 22% respondents knew about the nearest eye bank and who should be contacted, which is quite low compared to some other studies from the country. Low willingness among females is similar to other studies in the country due to less exposure of women to mass media and low levels of education. Young population were more willing to donate their eyes, similar to other studies. Nearly 10% of population were not willing to donate due to religious disbeliefs. So to conclude, multi-pronged approach needs to be developed to increase the awareness among people with low educational status, rural population, females and elderly age group. The major proportion of current awareness for eye donation is through NGOs and campaign by government agencies through television, newspapers, radios, pamphlets. Awareness through celebrities, youth associations, senior citizen association has to be promoted more often. Also, these online systems have been developed by various states so that we can register our names to pledge for eye donation. Such initiative should be taken by all the states in the country. Prominent display boards at the hospitals, mortuaries, community gathering places, railway stations, bus stops and various other places, and observing eye donation fortnights in the remote areas too can further increase the awareness and knowledge among the target population. Moreover, our outreach camps should also focus not only on cataract but on identifying and bringing in patients of who are corneal blind so that they can reach us and can benefit from keratoplasty. Okay, thank you.
You are in a private setup or you are in an institutional setup?
Sir, presently I am in a private setup, but when the study was there, I was in a government setup.
Okay. No, but then could you recommend to your civil hospital authorities where you can, and have you taken any measures for that?
Sir, it's already ongoing. Like LV Prasad Bhubaneswar, they have the representatives in our hospital who take the initiatives and they are very actively involved for all these things, sir. We distribute pamphlets and for every patient coming to the OPD, and we have taken steps to promote this eye donation awareness to the rural areas also during that week, sir.
Yeah, but because you said that this was a rural area based study,
Tribal
so
based.
obviously we expect that the awareness can be less. But then, do you think that putting such hoardings or the banners or the
Yes,
handbills at the ICU setups will be of
Yes,
any
sir.
help? Because
Yes,
few of
sir.
the hospitals are already following that.
Yes, sir.
Are you doing that?
Yes, sir. It's already done, sir.
Okay.
Yes, sir. Thank you, sir.
So good initiative to taken. I think eye donation must go everywhere in the country.
Yes, sir. Yes.
Thank you. The next presenter, please. Dr. Vasu. Next to be in line is Dr. Vandana. Please be ready.
First one, Upperwala.
Set the timer also and start the slides.
Can I start? Good morning. I'm here to present the data on technician and tele-ophthalmology assisted ROP screening in rural Tamil Nadu and Andhra Pradesh.
Just a minute. It is not seen.
Okay, you tell me to start, I'll start.
Hello. Prahan. Now you can start.
So good morning. I'm here to present the data on technician and tele-ophthalmology assisted ROP screening in rural Tamil Nadu and Andhra Pradesh. ROP is a blinding disorder affecting preterm babies, with India accounting for a majority, with roughly 35 lakh babies needing screening for ROP in India alone, and in the state of Tamil Nadu about 1 lakh babies need screening. And in India, ROP affects the babies of underprivileged parents, especially in rural areas, and the incidence of ROP in rural areas is largely unknown. Indirect ophthalmoscopy, which is a gold standard, is not a practical option for ROP screening in rural areas due to logistic issues. Hence, we envisaged Project Vision on Wheels, which was started in June 2018 to identify the babies in rural Tamil Nadu and Andhra Pradesh with ROP by a handheld retinal camera, the Trinetra Neo, and trained technicians backed up by tele-ophthalmology to ensure their prompt treatment with laser. The aim of the study was to analyze the 3.5-year data of the project from June 2018 to December 2021 and analyze the incidence of ROP and the characteristics of babies requiring laser according to birth weight, gestational age and post-conceptional age. The Trinetra Neo was used to screen the babies, and here's a video showing that. And the screening and the treatment of these babies of poor economic background were done totally free of cost. And we had 11 centers spanning rural Tamil Nadu and Andhra Pradesh, with Nellore, Ongole and Tirupati in Andhra Pradesh. The babies needing laser were promptly shifted for free laser, and these are the results. We screened about 18,117 babies, and number of babies which underwent laser were 1,046. And this is a graph which shows that the numbers of babies which were screened increased exponentially over the years, and 172, 279, 244 and 351 babies underwent free laser over the several years. And this is a graph which shows exactly that. You see that after the first year in 2018, as we go down, we see that there's a 50% reduction in the number of babies requiring laser and 100% compliance to treatment after the first year. This is the year-wise distribution of laser babies according to birth weight, and you can see that maximum number of treatable ROP babies were in the 1,000 to the 1,500 gram birth weight category, accounting for 50% of the babies which were treated, as is seen in this. And also there was a substantial percentage of babies in the higher birth weight category, and especially you can see that greater than 2,000 gram birth weight category, you can see a trend of decreasing treatable ROP over the years. And this is according to gestational age, and the maximum number of treatable babies were in the 31 to 35 weeks gestational age group, as is seen in the graph as well. And there is a falling percentage of treatable ROP in greater than 35 weeks gestational age with time, as is seen in this purple line. And in 2019 especially, there was a key finding. In 2019, if you see the greater than 35 GA category, 11% was treatable ROP, which fell to 7 and 9 over the years. This is the year-wise distribution according to the PCA. Again, 36 to 40 weeks PCA was the highest number of babies with treatable ROP, and this is seen in this graph as well. And also the falling percentage of treatable ROP in more than 40 weeks PCA with this time, and this purple line is also demonstrated very beautifully. So the majority of laser babies in our study were in the 1,000 to 1,500 gram birth weight, 31 to 35 GA, and 36 to 40 PCA as well. And so throughout all the years, the majority of babies requiring laser belong to the relatively higher GA and the PCA groups when compared to Western data, and also in relatively higher GA groups like greater than 35 weeks GA, greater than 45 weeks PCA also, we saw a substantial percentage of babies requiring laser. We did statistical analysis with chi-square test, and all the associations between birth weight, gestational age, PCA, and the number of babies undergoing laser for ROP over time were statistically significant. And if you see an association between ROP and birth weight, you can see there's an yearly increase in the number of babies with treatable ROP in the 750 to 1,000 gram category, and decrease in the greater than 2,000, which was statistically significant. And similar findings were noted in GA and PCA also over time, statistically significant associations. So this is commensurate with the Indian experience of ROP occurring in larger babies, and it's statistically significant finding of decreasing treatable ROP in bigger and more mature babies, and increasing treatable ROP in younger babies over time could be attributed to the success of a committed screening strategy like Project Vision on Wheels in reinforcing good neonatal care in the rural areas. This is the first such study in rural Tamil Nadu and Andhra Pradesh to document this healthier trend and show statistical significance as well. It is the largest data till date according to Medline search of technician and teleophthalmology based detection of ROP in the rural areas in the twin states of Tamil Nadu and Andhra Pradesh. Thank you very much.
Wonderful presentation, ma'am.
Thank you,
All
sir.
the slides were very nice, and this initiative must be taken all over the country. There was no awareness in the past, but after that court judgment against ROP
Yes.
has awakened most of the not only ophthalmologists but even pediatricians and neonatologists, and they must be taken along with our study and that knowledge to be spread everywhere, like gynecologist, obstetrician, neonatologist, and ophthalmologist. All of us must work all together to prevent further complications. Thank you.
Thank you, sir. Namaste.
The same series, I would like to add that just to present the data, your flawlessness was nice.
Thank you.
In fact, it was very nice to see the content and the flow of language and the communication what you were doing.
Thank you.
Nice.
Thank you.
Okay. Next presenter, Dr. Vandana. And next to be in line is Dr. Suraj Singh Sanjam. Dr. Suraj Singh is there? Yeah. Sorry. Okay. Why were you late?
global warming as an eye hospital, what is the options? So these are my co-authors with no financial interest and the objective. So global warming is one of the largest threats of the 21st century, and it is said that the healthcare facilities are supposed to be the 5th largest polluter of carbon emission, leading to global warming. So what are we going to do about this? So for the purpose, we were trying to assess the carbon footprinting of our tertiary eye institute and the measures taken to tackle the same with the green cover present in our campus. So it was a retrospective study for a period of 1 year from March 2018 to 2019 to assess the carbon footprinting per patient undergoing cataract extraction at our tertiary eye institute in Shankara Hospital, Coimbatore. So what we did was, we tried to calculate the carbon emissions produced during the surgical procedure, and then the measures to counteract the carbon emission produced using our hospital green cover. So most of the cases that we did was a small incision cataract surgery, and we tried to analyze what all the instruments that we used, the materials to do a small incision cataract surgery. They were basically one plastic drape of the size 45 by 30 centimeters, one crescent and keratome blade, two 2cc disposable syringes, one 26.5 disposable needle, and one IOL case. So on adding of all this, the cumulative addition was around 310 grams of plastic. Now we all know 1 kg of plastic emits around 1.2 kg of carbon dioxide on recycling or reusing, whatever. So each case of SICS which produced 310 grams, it came to an around 3.70 kg of carbon equivalent. But then the number of cataract cases that we operated for the year of 2018 to 2019 was around 32,000 cases approximately. And the cumulative effect of operating 32,000 odd cases of SICS for that particular annual year came to around 113.13 tons of carbon dioxide, which is quite significant for the atmosphere. Now, coming to the estimation of carbon dioxide absorption. So we use this method called biomass assessment, which illustrates the amount of carbon that may be sequestered by the trees, and it is an important indicator in estimating the carbon sequestration. 1 ton of carbon storage in the tree wood represents around removal of 3.67 tons of carbon dioxide from the atmosphere, and in turn releases 2.67 tons of oxygen back into the atmosphere. This is approximately 50% of the dry biomass comprising of carbon, and this was used to calculate the carbon dioxide which is being consumed by our green cover. So coming to our hospital and area campus, we have a campus of 5 acres, out of which the hospital area covers around 1 acre and the green area covers around 4 acres of land. So this is the image, a drone image captured, and if you see, the central part is where our hospital is there, and the surrounding area is the 4 acres which is surrounded by the green cover. So these are all the trees which have been planted, but basically they are all indigenous to the Indian weather and climate, like jackfruit trees, areca trees, neem trees, ashoka trees, as well as coconut trees. Along with that, we have planted medicinal plants like aloe vera, tulsi, hibiscus, etc. plants. And the last point, we have implemented this Miyawaki method of plantation to mitigate carbon dioxide equivalent of our campus. So if these are the images of our hospital, where this is the entry to the campus, this is a side image of our hospital, this is the back door entry or the back gate entry of our hospital. This is an image taken from the terrace or the balcony of our hospital. This is from the hospital if you take the image outside. And this is the trees which have grown according to the Miyawaki method, where if grown at a distance of 5 meters, the trees start competing with each other to grow faster. So this way we'll have a faster growth of trees. So now the cumulative absorption because of this green cover was around 133.22 tons of carbon dioxide, where the SICS released around 113.13 tons of carbon dioxide. So in the graph which is here, the surgery produced around 113.13 tons, whereas the absorption was 133.22 tons, which was an excess of 30. So discussion, 5721 surgeries per million is the estimated annual cataract surgical rate in India, and it is going to rise because of the increase in the aging population. Majority of the emissions arise during the supply equipment and pharmaceuticals. When UK produces a carbon footprint of 120 kilograms of carbon dioxide, our hospital carbon footprint is only 3.7 kg of carbon dioxide. Though the cumulative load is around 113.13, the absorption is 133.13. So conclusion, with an average number of 32,000 small incision cataract surgeries being done, carbon dioxide equivalent and carbon footprinting is highly significant, having a tremendous impact on environment and global warming. With maximum recycling and reusing, wastage generated and minimal use of disposables, contribution is minimal. And this has been done by most of our hospitals in India, which is commendable. But along with that, the humongous green cover of our campus, we are able to erase the burden with ease, and our tertiary eye care center can be a model for the care setups, not only eye hospitals, as well as the future other hospitals, to arrest carbon footprinting and mitigating global warming. My references, thank you so much.
I think wonderful presentation. Out of the box thinking, I must say. Apart from routine presentations, what I noted here, most of these studies are related directly to ophthalmology. This is something else. Previously, I thought why this presentation is there and only related to eye hospital, maybe related to some general hospitals also.
Yes.
But then you have correlated it nicely with eye hospital and the
Yes.
environment.
Great.
So good study.
Thank you so much.
Thank you.
Thanks.
Any question? Any question from those?
Actually, it is in context to the fact that places like metropolitan cities where the 4 acres of land can be the not available.
Yes.
You can start the presentation.
No, sir. He said this. He's just opening. No, just 10 seconds.
So, thank you, sir, and other colleague, and for this opportunity as well. So, today I'm looking interest. So, anyway, the purpose of my talk for today is like I want that all the professionals working in the ophthalmic sciences, it's time to know what is all about assistive technology for visual impairments. So, the managing low vision in a blind. So, it's time to know what is assistive technology for visual impairments. Because that, as you know that people with suffering from low vision and blindness, there's no other means to cure the disease. So that the ultimate goal is how to manage those people suffering from low vision and total blind. So with the help of assistive technology, this is all about a model that we developed, which support from WHO. This is improving access to assistive technology for visual impairment in Delhi, the school-based model. So coming to the assistive technology, so first we should know the assistive product. Assistive product is a simple product which can enhance the function of the human. Suppose, for example, someone is having difficulty in seeing, so wearing simple spectacles, so spectacles becomes assistive product. So it can be software, it can be hardware. So when you say the assistive technology, so it means the product means the related system. The related system means you have to assess, you have to prescribe, you recommend it, or then give a training how to use it, okay, over time. So this is the assistive product and assistive technology. So assistive technology is something like, it's not to be treat or cure the disease. Okay, this is a simple product to be used by a person suffering from some form of limitation. This is all about assistive product. So these are simple assistive product from the high end to the low, from the low end to the high end. So you have the magnifier, you have the large keyboard, and the embossed math, and so many assistive products, talking, calculator, science and math assistive product, and braille, USB recorder, and other one is a very high end, cost, I mean, in terms of thousands of dollars. So coming to the background, so as you know, the assistive technology for students, the full vision impairment helps students in terms of improving their academic skills, non-academic skills, and their independent living skills, social inclusion and participation, and also problem-solving skills. So there are so many benefits about assistive technology. And despite the well-known benefits, what is happening is the poor availability of assistive technology for visual impairment in school for blind in Delhi. Maybe other part of the state also. And a study reported 11 out of the 52 device assistive product. So in 6 out of 10 schools are present. But when you come into the braille, slate and the stylus, so there is only 9 out of 10 schools are available. So that means the majority of the assistive product for visual impairments are not available in the schools for blind in Delhi. So and at the same time, very few trainers about assistive products in schools for the blind. And this is a quick survey we did it. So here you will see that this is a classification of the assistive visual impairment. So we did it that we classify this different this is related to the my presentation. That's why I saw. So this is the objective to design a school-based model to improve access to assistive product in schools and identify the types of ocular mobility and among the students. The primary objective, our focus is the primary objective, how to develop, how to start this assistive technology training in schools. This is very challenging. For that, so we, out of the 24 blind school in Delhi, so we identified 2 schools. One is girls' school for the blind, another one is boys' school for the blind. So it is very challenging. So it's very difficult to convince the principal and the secretary. So they don't know what is the assistive product. These new things we don't know. So we are not interested. So we repeatedly talk with them, principal and secretary. We had a meeting a couple of times, and finally, so we became successful. Then we were able to convince the teachers. Then luckily they provide a dedicated room for assistive technology for visual impairment training for the students. So these are 2 schools for the blind. As you know, there are 25 schools in Delhi. So we have selected 2 schools. And see, for the training, we have a low vision team. Okay, so for the training assistive product, we divided into 2 different categories. One is the BAD, one is TED. BAD means visual-based assistive product. There is your magnifier, large print book, CCTV, and those are the visual-based. And second one is the visual substitutions, that is tactile and sound-based. There are so many products based on tactile and sound bases. So for example, DesiBook, Sonic Leveler, digital auto recorders, Victor readers. So in the training, so these are the classification you will see here, that visual loss range, WHO classification. For our purpose, we classify that visual impairment, low vision up to 160 and less than 160 blindness. And see in the other side, you will see the this flow chart. So students, we triage into 2 different groups. The group 1 is the BCBA, the best corrective vision acuity, better than 160, and the group 2 is the best BCBA, less than 160. So accordingly, so category 1, category 2, just simple, using technique we can categorize in the school, so we don't have to go detailed examination. They have the certificate also. So we categorize it category 1, category 2 for education purpose, what sort of assistive device should be provided to training, and for orientation and mobility, we know that cane, the walking cane. So different types of walking cane, because low vision person, they don't require the long walking cane. They just need the guide cane. Whenever they require, they use it. Otherwise, they should put it in the pockets, something like that. So as I said, so we classify the visual impairment. This is a well-known study. You will see here, so around 50% of the students in schools, so in the downstairs, around 50.6 students, BCBA better than 160. So they'll be needing some sort of visual-based assistive product, like you have magnifier, you have large print book, and so many assistive product. And the near BCBA, 28.8%, so they will be requiring large print book. So this is a simple classification we did. And this is training, so we started providing training, and the students, boys and girls, and for training purpose, we need to divide in small groups. So we can give a large number of groups at the same time. Sometimes one-to-one training, they are small group, maybe 3 or maybe 2 students. So this is a training we provided, different this thing. And this is a training manual. Results, so far 100 students are being trained, boys and girls, and the device, walking cane, third-party special apps for the smartphone, and Desi player, digital access. This is this Desi player is like this reading material will be converted to the accessible software material. Then it will Desi player will play what is that in the content. And Victor Reader, .mini, USB recorder. These are the assistive products we provide training. And this is the student. I just wanted to use last 2 slides. So this is the recording. See. Oh, boys.
To sum up.
This is the last one.
ट्रेनिंग दी है अभी तक
हमने डीसी प्लेयर, विक्टर रीडर और स्मार्ट विजन क्लासेस की ट्रेनिंग दी है।
अच्छा, इसमें डेजी प्लेयर जो है उसमें हम क्या करते हैं?
सर डीसी प्लेयर में हम रिकॉर्डिंग कर सकते हैं, और जैसे हम अगर स्कूल नहीं गए हैं और वो रिकॉर्डिंग करके हमारे लिए ले आए, उसके बाद हम उससे पढ़ाई कर सकते हैं।
अच्छा,
और लेक्चर भी रिकॉर्ड कर सकते हैं।
अच्छा,
इसमें वाईफाई भी कनेक्ट हो सकता है और हम इसमें ई पुस्तकालय से भी बुक रीड कर सकते हैं।
अच्छा।
इसमें खुद की मेमोरी है, इस वजह से हमें अलग मेमोरी डालने की कोई ज़रूरत नहीं होती है।
आपको ये डिवाइस जो है कैसा लगा वो? आपको लगता है वो यूज़फुल रहेगा आपके लिए?
यस सर, मुझे ये डिवाइस बहुत अच्छा लगा और ये हमारे लिए बहुत यूज़फुल है पढ़ाई के लिए।
अच्छा।
Okay, we'll go ahead.
मेरा नाम
So this is the smartphone. This kids. So
ऐसे नॉर्मल ऐप्स यूज़ करते थे।
अच्छा। उसके बाद हमने आपको यहाँ पे ट्रेनिंग दी है ना? तो आपको हमने ट्रेनिंग में आपको क्या क्या ऐप्स सिखाई है हमने?
आपसे मैं कोई इंस्टा रीडर, मनी कैश रीडर, इन
अच्छा।
सब ऐप्स बारे में पता चला।
अच्छा, इसमें इंस्टा रीडर में क्या करते हैं बताइए?
ऐसे नॉर्मल।
So the last conclusions, we know that a sizable number of students would be benefited with the visual base and other smartphone based apps. Students are interested to have the IT training in the schools, so that what are available, advanced, even the advanced technique also. It is important that all students can access the appropriate assistive technology, and it's very important let them aware right from the beginning before go to the college level, university level, and before going to the PhD level. Because once they know at the very beginning, they will definitely help to in terms of employment and job. This is the way forward, and because this is another issue we found is a dental problem among the blind schools, and for the girls schools, girl students, that the menstrual problems, menstrual hygiene problems. We found it, but they don't know how to, like that's why we need to contact that option any faculty or residents, so that some kind of accessible material for the girls blind school blind. Thank you so much.
Thank you. It was a nice presentation. So with this, I think we are coming to the end of the session. Dear friends, we started on time and we're finishing on time. We'll take the group photograph. The presenters who are present here, all of us please come forward. Thank you so much. And we are handing over the session to the
Next team.
time.
But I think your topic was very interesting. Needs more elaboration. Unfortunately, you came too late.
Yeah, that's okay.
Now you're on
Before he starts, I must say that what sir has said,
Sure.
that most of the times we are at fault. We are telling to our patients that this surgery is only within 5 minutes. Then you can go home while driving your own car. It is very simple. So what patients feel that if the surgery is so simple, within 5 minutes, why are you charging so much? And if there are no results, if there are some complications, again patients are troubling you a lot. If you take more than 5-10 minutes for your surgery, what you have promised, suppose there are some complications and you have tackled in a nice way, and if 1 hour is gone, patient will not feel that you have done the nice thing. What they will say, why there was so much of time taken, why there was some complication, and why you took more time. So that goes against you. So telling so many promises, giving so many promises to patients and relatives is going against us. So all these things one more time to tell our patients and relatives is boomeranging. So be careful, explain everything in a nice way. It is not the simple surgery, that's what you have to tell. But we are telling that it is very simple, but then cost is not comparable. So it is simple for the skilled surgeon. So it is a skill what you have. But suppose the complication is there, suppose the patient is complicated, that particular scenario is complicated, you are going to tackle the thing. In that case, though you are doing it in a nice way, it doesn't remain simple from patient's perspective, from the relative's perspective. So you have to be careful.
For that, I have got a standard sentence to say that you want to look in the time or you want to have a good surgery. So 5-7 minutes here and there doesn't make any difference. But be particular to have a good surgery. सर वो मेरा पिछला ऑपरेशन 5 मिनट में हुआ था, दूसरे को अभी 10-12 मिनट लग गया. ठीक है, एक ही हाथ की 5 उंगली सेम नहीं होती है. So same as that, you have to find some simile, so which will pacify the patient. Are you ready? I'm just killing the time, because finally it is like कोई political सभा जैसी होती है कि वो मेन बात करने से पहले जैसे लोग बोलते हैं.
Otherwise, all of you might have left the hall.
Good to go.
Good morning, everyone, respected judges and my dear colleagues. In keeping with the Go Green initiative of the AIOS, I, Dr. Ramya Nadik, consider it my privilege to present today my paper on global warming impact of fluorinated gases in ophthalmic surgeries at a tertiary eye care center of India. This paper has been co-authored by my mentor, Dr. Rajiv Raman sir, and we have no financial interest. Global warming, as we all know, is the greatest health threat of this century. The healthcare sector carbon footprint accounts for 4.4% of global greenhouse gas emissions. Operating theatres are considered as resource-intensive areas and necessary for high-quality care. Hence, their environmental effects are not given adequate attention, and it is time for us to embark on the path of greener healthcare practices. This is a retrospective study spanning for 5 years, held at a tertiary eye care facility in South India. Since the procedures were completed prior to the inclusion, it was exempted from ethical approval. The aim of the study was to report the environmental impact of fluorinated gases used for intraocular tamponade procedures. The data was acquired from electronic records, operation theatre database, and store inventory. Procedures involving the fluorinated gases were included in the study, and those using air tamponade or silicone oil were excluded. The gas used for tamponade was as per the discretion of the surgeon, and the dilution as per the case requirement. The environmental impact calculations were done based on a calculator developed by Musa et al., which converted the volume of the gas to its mass by modified ideal gas law formula at the standard temperature and pressure for the canister. It was then converted to their equivalent amount of carbon dioxide in the atmosphere. Due to the variations in the canister pressure and atmospheric pressure, mass was used as a metric to permit comparisons because it is constant regardless of gas pressure and temperature. Coming to the global warming potential, we calculated the global warming potential for these fluorinated gases. Global warming potential is nothing but the amount of heat a gas absorbs in relation to carbon dioxide over time. So different gases have different atmospheric lifetimes, and fluorinated gases have several thousand years of atmospheric lifetimes, which makes their global warming potential significantly high as the time increases. We have used GWP 100 or global warming potential of over 100 years in our study. The results were tabulated, and we found that 1.4 metric tons of carbon equivalent mass was generated out of 1842 procedures that were carried out. Although most of the procedures did use C3F8 and only 24.37 procedures used SF6, it produced more than 50% of our carbon emissions. The most common indication for surgeries using fluorinated gases was macular hole surgeries, and even in these surgeries, most of the procedures did use C3F8. Comparing scenarios, if a single fluorinated gases was used in all of the procedures in the study period, we found that we could increase our carbon emission by almost twice if only SF6 was used, and we could have decreased it considerably if only C3F8 was used in all procedures. This study assessed the carbon equivalent mass for various fluorinated gases and suggested the possibility of global warming in the next 100 years. Similar studies have been done in UK, but this is first of its kind to be conducted in India. The environmental impact of fluorinated gas in ophthalmic surgery has received very little attention because of the limited intraocular volume employed. But the carbon emission is substantially more than anticipated because of the high GWP value. Although SF6 was used in only 24% of the cases, it resulted in more than 50% of our carbon emission. Therefore, we can consider using air tamponade more frequently as an alternative when clinically safe to do so. There have been reports that produce comparable surgical results with air tamponade as well. Additional research can be done for employing C2F6 at lower concentrations as well. Giving perspective to our study, we compared our carbon emissions to day-to-day activities and found that driving a diesel car for 6,000 miles or using an electric heater for 6 hours a day for a year would produce the same amount of carbon emission in the last 5 years that we have produced. To offset this would be a simple afforestation drive using 14 trees per year for 100 years to offset 14,000 kgs of carbon emissions that we have produced. The limitation of the study was we did not measure the carbon footprint related to production, delivery, storage, removal, or disposal of these canisters. However, it is a pioneer study in identifying the problem statement, directs towards designing protocols on usage of air as a preferred agent for short-term tamponade, and also motivates medical facilities to devise strategies to make health care practices greener. Thank you.
Good presentation again.
Thank you,
There was
sir.
one more presenter on almost the same lines.
Yes, sir.
Nice study, what you have done.
Thank you,
So
sir.
again, as Dr. Ambedkar sir has said, that it's possible where the space is available.
Yes, sir.
And for the bigger hospitals, where the acres of land is available. And that particular model really has worked well. That's what we have observed. But let's maintain it in the bigger cities and metros where less space is available. Maybe government, again, previously I have said that there are government rules and regulations hospitals in various cities now. So daycare center that way is the option, but which is not given by many more states in India, because there is no special entity as daycare center. It is only clinics or hospital, no entity in between like daycare center. So I've been asking this particular entity as special category in various states, if they give that daycare center facility and that special registration, if it is provided, which can be benefited for our specialty or ophthalmology maternity, so that most of us can manage that daycare center, like do the surgery or do the procedure and send the patient home. Thank you.
Thank you, sir.
Suraj Singh has reached or not yet?
We will wait for some
I think we need to wait, but
because
then
the next session starts at 10. So the
9:50.
person is just on the way. If he comes, we will take him and justice can be given to him. Otherwise, the podium will be vacated exactly at 9:55.
Yeah, but then meantime we have some time to discuss. I would like to especially mention Dr. Vasumati, because most of the data which was, no, I can have a seat, nothing very good. I just want to appreciate you for a reason that there are few presenters, those who are present in the audience as of now also, few have left already. But then I think whatever presentation she has done for the data, most of the people have done the data presentation as just a gist, while that was something different what she has done in various forms and associated with the actual procedures and everything. So her slides were, I appreciate her presentation, the flow as because I have some time, so just people are sitting here, so there are few juniors also as I'm seeing them. So I think next our conference we should think of having another session of how to make the PowerPoint presentations more effective. I think that would be another good interesting subject for you, because your presentation was very nice. And another thing that probably again getting back, for the both of us are on the same generation, but then in your generation people are looking for most of the things through the AI. I go back to my this thing. Are you Dr. Suraj Singh? Okay. No, because we are just waiting. It is like, you know, in IPL, if you, the next batsman doesn't come within 90 seconds, then automatically he is not eligible to come. But he has got a time till 9:55, another 7-8 minutes more. So for the juniors, as I'm getting back on this, is that looking at the current scenario where we are more into the social media and other things, but finally on a long-term basis, we are not in the manufacturing sector. Suraj Singh?
Yeah,
So please come.
Upload your presentation. Relax. We'll give you 2 to 3 minutes just to
So by the time he uploads, so that the last visitor is also here now.
relax and then you can present. In between, if you have got some points to discuss, we'll discuss till he starts his presentation.
So we are not from the manufacturing sector, we are dealing with the human beings. And there is a mind in everybody's person as a human being. So try to understand the other side of the story also always. Like you are an eye surgeon. Suppose your parents or someone known to you gets any heart problem or any brain problem or anything, where the bypass or no bypass or whatever may be the case. You are as bad as a lay person, though you know general medicine as such as an MBBS doctor, but then you are not technically aware about the very fine intricacies. So you may not be knowing what is going to happen, what is on pump, what is off pump, whether off pump is possible, on pump is dire necessity, and so on. So effectively, you will also have the same questions that are there in the mind of a common person. So whenever you always explain to a patient or their relatives, see that your communication is good enough, confident enough, and always people are thinking that itne time mein itne patient hona chahiye. I think that cannot be the way. Finally, somebody may have, I don't say that you should entertain Google Baba, because people nowadays are coming with Google Baba ki sir usme aisa likha hai, waisa likha hai. But I always make it a point that better to ask Google is first. Second is what Google gives is information, and it is not the knowledge. You have to use your wisdom to convert that information into knowledge. So try to make the relatives or the patient understand, even if it's through Google Baba, that whatever you have received is merely the information. So never ever use this at a wrong place, and don't try to teach us. I am very blunt probably at my age I can be that absolutely blunt with saying that you better consult Google only and need not come back to me at all. So that's not an issue. But then as a beginner, you may not be able to be that rude with the patient. But always remember that making them to understand in a polite way and a proper tone of a difference between the information and knowledge. Like everything is available. How to make atom bomb is available. How to make a car, even BMW, Mercedes or anything, you can see it on YouTube. You may get everything available from the vendors, but you cannot make the same car as the BMW original company manufactures. So similar way, you make understand it is ready to go. Fine, I back out. And
before that, what sir has said, how to prepare atom bomb. Don't do that. How to prepare the bomb. If you just the moment you search, you are taken to police. It is that way. It is very serious. Google is very serious. If you try to search how to prepare the bomb, it is traced, and police come to your place, or they are tracing the person who is putting that in search. These 2 to 3 things they are there. That's why if you search on Google, you are gone.
Instead of making the atom bomb, I started making Mercedes or BMW. You are on
treatment. It will help patients in remote areas to access high quality, cost effective neuro-ophthalmic care. It will be useful in triage, diagnostic consultation and long-term treatment monitoring. It is an important alternative for elderly, immunocompromised and mobility challenged patients. The essentials for teleneuro-ophthalmic care are best corrected visual acuity, color vision, central fields by Jerem screen, pupillary examination with swinging flashlight test, fundus examination with a high quality fundus photo. Pupillometer, Humphrey visual field analyzer and OCT can be incorporated in future for furthermore evaluation. So telehealth is increasingly recognized, and teleophthalmology does not substitute but supplements and complements in-person neuro-ophthalmic care. Many advantages has been explored during the pandemic, and it will continue to serve the rural population. It is an excellent tool in triaging patients and to sensitize them to get immediate medical attention who are otherwise reluctant to visit a hospital. So it is very helpful in neuro-ophthalmology services where timely diagnosis and intervention is very important, which will be vision and sometimes life-saving. Thank you. These are my references.
Thank you. Thank you. I think nice presentation. Teleophthalmology is need of the day, and definitely artificial intelligence is again coming up. Whether it will be useful or not, or double-edged sword, we never know, because it shouldn't replace the human being. And
Yes.
then so many things like complicated things may be there, like somebody can post on your behalf some video, some audio, never know. So let's go forward. Teleophthalmology is need of the hour. I think you are connected very well with that neuro-ophthalm.
Yes, sir.
Nice, good. So,
AI in the current context is going on the negative side again. But then finally we also need to understand, because there are a lot of youngsters, but I would like to put that nothing, only that AI works because the human connectivity is getting lost. So try to get connected with the patient. Everything, not that everything is possible with the AI. The human brains, maybe another 50 years, we are not sure. By the time, I hope I may not be there, and you are also not there after 50 more years.
I think most of the things we have created trouble for ourselves, like the surgical skill. We are telling to patients that machine will be doing, this machine is very costly, so the cost of the surgery is more. Robotic surgery has come. So people have started thinking probably surgeon is not going to do the surgery, it is a robot which is doing. So maybe the thing can come in the minds of people, like you can just stand on one machine and the diagnosis will be there, or sit in the machine and the treatment will be given like that. All those are of course fantasies. So human element should not miss. So it is direct patient and doctor relationship, that personal touch which matters. Chair time has to be there. Don't feel that you have got so many machineries and you are treating the patient in a nice way with high-tech technology. That is not going to serve the purpose. The patient connect should not be missed, and that is the basic thing. And human doctors, the human brain should also be correlated in medical treatment in future also. That should be our aim. Thanks.
Thank you, sir.
So the next presenter is Dr. Ramya, and after that.
A very good morning, everybody. I'm here to present my clinical study on management of patients with orbital sarcoidosis. So as we know, sarcoidosis is a multi-system disorder. Most commonly, it generally affects the lungs. Ocular involvement as such is generally very rare, and if we do see any cases, always in the form of a uveitis. So I did a literature search, and the number of large case series are very few, and especially there are hardly any other than few small case reports from India. So my study was on the clinical features and management outcomes of orbital and adnexal sarcoidosis. It was a retrospective study. We studied all patients who present with sarcoidosis for the last 10 years at 2 tertiary eye care centers. We collected the demographic details, the clinical features, what is the treatment given to each patient, and the management outcomes. So only patients who presented on histopathology with non-caseating epithelioid granulomas were included, and we made sure that we ruled out all other causes for epithelioid granulomas. When all patients underwent imaging either in the form of an MRI or CT, HRCT tests were done for all patients once histopathology confirmed sarcoid, and serum AC levels were done. So our study included 21 patients with a mean age of 47.7 years. We saw that we had a female preponderance, as all seen in literature. Right and left eye were equally involved, but 5 patients had a bilateral involvement. The mean duration of symptom onset was 2.45 months, and we noticed that the most common presenting feature was an upper eyelid swelling, followed by lacrimal gland enlargement, a palpable mass, proptosis. We had one each of a sac swelling and a conjunctival nodule. One patient had a bilateral lacrimal gland involvement. None of our patients had intraocular, so anterior segments were normal, and there was no past history of tuberculosis. Imaging was done in all except 2, the reason being one presented like an acute dacrocystitis and the other had a conjunctival nodule, hence imaging was deferred in these 2 patients. We found lacrimal gland to be involved in 4, whereas 8 patients had a diffuse or had an orbital soft tissue mass, of which 3 had a diffuse lesion, the remaining had well-defined lesions. Extraocular muscle and conjunctiva, you can see, were just 1 each. So based on the clinical features and imaging findings, the most common initial diagnosis was either an IOID or a lymphoproliferative disorder. Since these patients had already undergone treatment elsewhere, hadn't responded to treatment, or there was some kind of a clinico-radiological mismatch, we went ahead with surgery, of which incision biopsy was done in 16 patients and an excision biopsy was done in 5 patients. All patients had characteristic non-epithelioid, non-caseating granulomas confirming diagnosis of an orbital sarcoidosis. HRCT chest was done in 19, of which we found that bilateral lymphadenopathy hilar was seen in 11, whereas 8 patients did not have any pulmonary involvement, and none of our patients had a past history of sarcoidosis for which they were taking any treatment. Serum angiotensin converting enzyme levels were raised in 10 patients, whereas lysozyme and calcium were normal in these 11 patients. So in accordance with the pulmonologist, we treated these patients. Oral steroids were given to 7 patients. 5 patients who did not respond with oral steroids were started an additional oral methotrexate. The mean duration of treatment was around 2 to 4 months for these patients. Observation was done in 3 because the mass was completely removed. 6 of our patients were lost to follow-up post-surgery. So mean duration of follow-up was 7 months, and in these 7 months we found the outcomes. Complete resolution was seen in 13 patients and a partial resolution was seen in 2, and none of our patients had any recurrence. So these are some of our patients. You can see this is patient 1 who is presented with the bilateral lower lid swelling, and MRI also shows an ill-defined mass and conjunctival nodules, which was shown to be sarcoidosis. The second patient is similar with the lower lid mass, and this is a patient with a bilateral lacrimal gland involving both the palpable and the orbital lobe. Here's a patient with a conjunctival nodule, and this is hilar lymphadenopathy. This patient was treated with steroids, and you can see this was only treated with topical steroids and a complete resolution. So sarcoidosis affects the lungs. Eye is seen to be involved in 25 to 60, and most often they say that eye involvement occurs secondary to a systemic sarcoidosis. So when we see the ophthalmic manifestations, it can involve any part of the eye. Starting from the eyelids, it can involve the sclera as well as the optic nerve in the form of neurosarcoidosis, orbit, and even intracranial involvement can occur. This is a patient, one of ours, who had a pure extraocular muscle involvement with tendon involvement. But clinically, when the patient presented, it looked very much like a active thyroid eye disease. And similar reports have been published in literature where sarcoidosis presents mimicking a thyroid eye disease. This is a patient who presented with an acute dacrocystitis, and we assumed it to be acute DAC, but she did not respond to analgesics, and hence we imaged and we found that she had a soft tissue mass in the medial canthal region, and she was diagnosed with sarcoid. Similar reports have also been published. It's important to keep this in mind because it's one of the important causes for a failed DCR, which is sometimes missed. So there's always a controversy in terms of diagnosis. Many authors believe that you can only diagnose an orbital sarcoidosis if a patient has a systemic sarcoidosis. But there are also debates against it, because there is published literature where not all cases of an orbital sarcoid on histopathology have a systemic involvement. This is a large case series of 30 patients where they noticed that only 11 had orbital sarcoidosis past history, 8 were simultaneously diagnosed, and 9 never developed sarcoidosis in follow-up. It's very important to do systemic workup for all patients to rule out a systemic involvement. So treatment for sarcoidosis is very straightforward. It's generally steroids as a first line management. Most patients resolve with oral steroids. In well circumscribed lesions, an intralesional steroid can also be given and shows very good response. In those who don't respond to steroids or those who have intolerance to steroids, you can start them on steroid sparing agents, and methotrexate works really well. If not for methotrexate, mycophenolate and cyclosporin. This is a literature review that we did. We found most studies had lacrimal, but ours had soft tissue involvement was more common. As to conclude, it is a rare disorder, but you need to keep it in mind as a differential, and so treatment in these patients generally has good outcomes, but it's important to have a long-term follow-up. Thank you. So we started based on the body weight, madam, 1 milligram per kg body weight. So based on that, we slow tapered it over 2 to 3 months.
Over 2-3 months?
Yes, ma'am.
So you gave it like on daily basis, or was it?
On daily basis, oral steroids.
No, I asked about methotrexate.
Oh, methotrexate. Methotrexate was given once weekly, and it was only given for patients who are not responding to steroid.
How much?
So methotrexate, we started 500 milligram and once week. 50 milligrams, sorry, and then we tapered it down. No, not by oculoplasty. We sent to the pulmonologist. Yeah. We never give immunosuppressants at our place. We always refer to pulmonologists and they start. Yes, yeah, they were monitored, correct, for it.
What this study has added new to the existing literature? Out of the upper limb swelling is very common, the treatment is much added, and the study population is also very less.
Yeah. But generally it's very rare. So in 20, so such a long duration, we only had 21. Yes. Most often they're misdiagnosed with tuberculosis. Yeah. Yes, correct. Yeah, most often we found everywhere lacrimal gland. Ours was more of a soft tissue involvement, where most people diagnose it as an IOID. So we need to keep this in mind. Yes, sir. Yes, sir, all the cases. Yes, sir. Yes, sir. So the muscle biopsy, we took the from the inferior oblique. So we expose the muscle and we take it from the orbital part, the muscle belly, and we take it along the long axis of the muscle. Yes, yes, sir. And in the other patient, because we suspected that there was some pathology for the lacrimal sac, we opened up the entire sac. So we just left a small frill of tissue, and the rest of the entire sac granulation tissue was removed completely. DCT, but again, a modified DCR, the entire sac tissue was removed and then created an osteum. Yeah, more like a DCT. Yes, DCT, yes, sir. Yes, sir. So in India, as such, there are not any cases reports of that. Yes. Okay. Thank you.
Thank you. So we'll move on to the our next speaker, Dr. Prabhisha Banerjee. Dr. Prabhisha will be speaking about autologous fat grafting, our experience at a tertiary eye care center.
Good afternoon, everyone. I'll be sharing our experience on autologous fat grafting. So autologous fat graft was introduced by Newber. He used an open technique for fat transferring. Now with the advancement in the technology, It has found wide application in aesthetic surgery, like facial recontouring, scar management, etc. So ours is the first study from India to report its use in sockets. This is a retrospective interventional study which was done between January 2019 and March 21. So we have used autologous fat graft in various types of patient, and these are the parameters we assessed for each patient respectively. Coming to the surgical technique, all the cases were done under general anesthesia. The donor site we selected to be the lower abdomen. A small stab incision was made, and the tumescent solution, which is composed of 100 ml of normal saline, 30 ml of 2% lignocaine and 1 ml of adrenaline was introduced in a fanning method. After 5 to 10 minutes, a 3 millimeter Coleman cannula fitted with a 10 ml syringe and luer lock was introduced, and fat was harvested using a negative pressure technique. So then it was left alone to settle down using the gravitational force. After it has settled down, the plasma, the serum was separated from the fat, and the remaining fat was transferred in a 3 ml of syringe, and then using a 20 gauge cannula it was injected in the recipient site. So the remaining fat, it was stored at -20 degree for 4 weeks, and after 4 weeks, if any patient required repeat injection, it was given. We have followed up the patient at the first week, 4th week and 6 months. So we have included 17 patients. The mean age was 30 years, and we found that orbital volume augmentation was the most common indication for AFG. In our cohort, the trauma was the most common etiological agent, and in the orbital cases of volume augmentation, the anophthalmic socket was the major number of cases, followed by residual enophthalmos after orbital fracture correction. We have used approximately around 5 ml of fats for these cases, especially the socket and the residual enophthalmos. And we noted that further augmentation was required for 3 patients, 2 with the residual enophthalmos and 1 with superior sulcus deformity. We have followed up the patient for a mean of 6 months, and resorption of this autologous fat graft was noted in 3 patients. Now out of these 3 patients, 1 required repeat AFG harvestation. 1 patient had already contracted socket and had already undergone multiple procedures. So we repeated a Dummies fat graft for that patient, and the temporal hollowness patient was a RB patient post radiotherapy. So we assumed that could be the cause of this atrophy. Now this is one young lady who had undergone fracture repair elsewhere and presented to us with superior sulcus deformity, and this is the outcome at the final checkup after autologous fat graft injection. Similarly, this is a middle-aged man who had undergone trauma, and he developed a tear trough deformity, and this is the outcome after autologous fat graft injection. Now this is the outcome we achieved in our socket cases. Now this Sidney Coleman, he introduced the latest technique of autologous fat graft transfer, and the usual donor site is abdomen. So it has been noted that harvestation with 3 millimeter of Coleman cannula give optimum results. However, smaller cannula is used for better results. And we noted that structural integrity is better with the sedimentation method. Slow injection assures better fat imbibition, and with volume augmentation in sockets, we can avoid surgical intervention like DFG. So optimum outcome is achieved. Fat cells also possesses mesenchymal stem cells, which gives a better skin remodeling also in this patient. However, much said, AFG survival is unpredictable. So blindness is the most severe complication that can occur. It occurs due to intraarterial injection of autologous fat. These are the limitations of our study. We could have taken a control arm with centrifugation, but we couldn't achieve that. So to conclude, it is a minimally invasive technique, and it can be used in the correction of residual enophthalmos. It gives optimum outcome. Cryopreserved fat, although it has been noted that there is depletion of stem cells in them, but we have found optimum results. However, further studies are recommended to see the fat survival and all. Thank you. These are my references. Yes, sir. So far actually we have the longest follow-up is 1 year only, and patients are doing good. At 1 year also we have found them to be doing good, but yes, 3 patients, as I already told you, so 3 patients required repeat injection at 4 weeks, and after 6 months we noted atrophy in those 3 patients in this series. Yes, sir. Yeah. Yes, sir. This is the initial phase, sir. We would definitely, in the long run, we may do a comparative study. Sir, it was stored at -20 degrees. Yeah.
So are there any other questions for this? Okay, thank you. Dr. Abhijit speaking about posterior medial canthal anchorage, a simple technique.
Very good morning to all present here. I am presenting on a simplified technique by name posterior medial canthal anchorage. It's not so. Yeah. Conditions which cause medial canthal deformities are age-related medial canthal tendon laxity, long-standing facial palsy, traumatic avulsion of the lid, cicatricial medial ectropion. Medial canthal deformity hampers the normal eyelid function with respect to tear drainage and ocular surface integrity, which causes eyelid malpositions like ectropion and entropion, which in turn causes ocular discomfortness, foreign body sensation, watering, punctate epithelial erosions, and blurred vision. Anatomically, medial canthus is very complex, considering its close proximity to the lacrimal drainage system. Correcting its disruption is challenging. Here we describe a new technique, transcaruncular medial canthal tendon anchorage, either with or without thermal medial thermoplasty. To the best of our knowledge, this technique of modified medial thermoplasty in combination with posterior medial canthal anchorage has not been described in literature so far. Our purpose of the study was to describe a simple, quick, reproducible and minimally invasive technique for MCT dehiscence and deformity. And this is a retrospective case series study performed over a period of 1 year from Jan 21 to Jan 22. And the patients included are 7 patients of facial nerve palsy with a significant lag of thalamus, 1 patient of old traumatic cicatricial medial ectropion, 1 senile horizontal lid laxity patient, 1 lower lid avulsion with canalicular laceration. All the patients underwent routine slit lamp examination, lacrimal patency being checked, all the preoperative data collected from the records regarding punctal position, the degree of medial canthal tendon laxity assessed by the lateral distraction test given by Olver system, lid contour abnormality graded using Gower grading system, any history of trauma was also noted. Post-operative outcome parameters are resolution of symptoms, restoration of normal eyelid contour, punctal position, medial canthal tendon laxity improvement. And all surgeries performed under local anesthesia in order to prevent the surgically induced canalicular injury. Lacrimal probe has been inserted. Primarily a caruncilectomy is done, and then as seen in the video, triangular area medial to the punctum is deeply cauterized using the radiofrequency cautery, followed by a double-armed 6-0 Vicryl passed in a horizontal mattress fashion from the medial end of the tarsal plate, including the diathermized area, in a posterior superior direction towards the posterior lacrimal crest, and exteriorized on the skin as high as possible. Wherever necessary, in some patients with a long-standing facial palsy, additional standard surgical techniques is also performed, like upper lid blepharotomy, mullerectomy, lateral tarsal slip, lower lid spacer, and subflift. all patients were followed up for a period of 6 months, where 9 out of 10 patients showed a symptomatic improvement with no epiphora. Ocular discomfort dramatically improved in 9 patients. 1 patient had some discomfortness. Lid contour was satisfactory in all patients. All had adequate lid tightening with lid globe apposition. Puncta was well apposed in 9 patients. Residual punctal eversion noted in 1 long-standing facial palsy patient. None of the facial palsy patient had a residual lid laxity. Lag of thalmos was reduced in all facial palsy patients. Here is a patient with a left-sided facial palsy who underwent posterior medial thermoplasty with posterior medial canthal anchorage suture, showed a well-corrected lid contour with a punctum globe apposition. And here one more patient with a right-sided long-standing facial palsy who already underwent direct brow lift with medial tarsorrhaphy somewhere else, presented to our institute with a wide lag of thalmos and high symptoms, who underwent right eye upper lid blepharotomy, lower lid spacer, SOF lift, along with thermoplasty and posterior medial canthal anchorage, showing a corrected lag of thalmos and also good contour with mild punctal eversion. And here is a patient with old traumatic medial canthus malalignment, post-surgery 2 weeks, showing a good lid contour and punctal apposition. And usually in a canalicular laceration repair with intubation often leaves a notch at the site of tear because of the lateral pull of the eyelid, which can be prevented with a counter-traction PMCA suture like this patient. And similar kind of suture is required in eyelid avulsion, where inferior to superior traction is required, which may not be possible with a simple monocanalicular intubation, which can be achieved with PMCA suture. Based on this reference, which describes the posterior medial canthal thermoplasty technique, we modified the technique and where modification as primarily caruncilectomy is done, then a diathermy burn applied, absorbable suture in a posterior superior direction from medial end of tarsal plate in the direction of posterior lacrimal crest. All patients had more than satisfactory outcomes with respect to lid contour, medial canthal integrity, punctal apposition, and symptomatic relief. Here I conclude, posterior medial canthal anchorage is a new, simple, safe, minimally invasive and effective procedure that addresses the MCT dehiscence and deformity in comparison to open conventional technique. And it reduces the amount of eyelid resection, reduces MCT laxity with no external scar, and maintains canalicular patency with some amount of compromised Horner's muscle function. Thank you.
Use the mic.
So by doing caruncilectomy, we are creating a raw surface which helps in the adhesion, sir, and also the suture tract fibrosis holds the lid against the gravity. With that concept, we used 6 ovicrils. Yes, sir, sure. Yes.
It's a good point. Actually, she is relying on fibrosis to set in and do the job. We can always try, yes.
Sure, sure, sir.
Especially
Yes.
with the effect gravity plays, it can always come back.
Yes.
So
How long is your follow-up?
Sir, up to 6 months we have followed up, sir. The visit was 2 weeks, 1 month, 6 months.
And no recurrence?
No, till now no recurrence, sir. Yes, ma'am. Ma'am. Yes, ma'am. Ma'am, one is non-incisional. Here we are not taking any incision on the medial canthal area. Second thing, by creating the raw surface itself, and we are anchoring against the gravity. Yes, ma'am. Some amount of the canalicular kinking, conjunctiva is getting contract. Yes, ma'am. Ma'am, canalicular kinking is a high rate when it compares to plication in comparison to anchorage. Ma'am. Longer follow-up, yes. Yes, ma'am. Sure. Yes. Sure. Okay.
Right. Thank you.
Thank you,
for
sir.
this. Our next speaker, Dr. Amrita Valli, Samya Mujib. Dr. Samya Mujib. But she's not available. She's not available. She's not available. Dr. Neelam is not available. We'll take her later whenever she arrives. We'll move ahead with the next speaker. So she'll be speaking about the sensational sural case series of patients undergoing surgical corneal neurotization.
Good morning, one and all. Today I'll be discussing about a case series of patients who underwent corneal neurotization. Corneal neurotization, as we know, it involves the transfer of a healthy donor nerve segment into a tissue to re-establish either motor or sensory innervation. It describes the restoration of structural nerve growth into the cornea to restore corneal sensation and tropic function. The main aim of our study is to report our practices and outcomes in treatment of neurotrophic keratitis through corneal neurotization using sural nerve grafts. It is a retrospective type of a case series involved in oculoplasty and corneal surgeon over 9 eyes of 8 patients over a period of 18 to 24 months. Moving on to the surgical technique which was done under general anesthesia. First, the sural nerve was harvested, about 10 to 15 centimeters of it from the mid-calf region. And here you can see from the right hand side, first the subro incision was taken on the contralateral side, and the supraorbital supraophthalmic nerve is identified and it is stacked. And then on the opposite side, sural nerve, the distal end of the sural nerve is divided into 5 fascicles, and then scleral or corneoscleral tunnels are made with the help of a crescent, and the 5 fascicles are inserted and sutured, secured to it around the limbus circumferentially in a neat manner and secured with 10-0 nylon. And the conjunctiva is secured with continuous interlocking sutures. Then the proximal end of the sural nerve is taken out through the upper fornix, and it is crossed over the nasal bridge and brought out through the contralateral subro incision that was taken, and it is coapted. Side to end coaptation is done with the supraorbital nerve, and then it is closed in layers. These are our results. The patients not only just went corneal neurotization but also underwent corneal surgeries like DALC and PKP, along with some other oculoplasty surgeries like tarsorrhaphy, dermoid excision, etc. So I'd like to particularly talk about patient number 3. This patient had left eye congenital anesthesia, corneal anesthesia, and underwent a contralateral corneal neurotization along with DALC procedure. 5 fascicle surgery was done, and it was sutured to scleral tunnels. In the postoperative period, about 24 months, we saw that the corneal sensations were present, the corneal sheen surface improved, and even the corneal reflex was present. Here I'd like to talk about patient number 6. This patient had both eye congenital anesthesia syndrome, and both eyes underwent PKP along with ipsilateral corneal neurotization. Sadly, right eye we lost to traumatic endophthalmitis. Left eye was followed up for 24 months, and this was a 3 fascicle surgery, suture to scleral tunnels. The corneal sensations were present. The overall ocular surface health as well improved. We did note that the patients with 5 fascicles had a faster and a better response compared to 3 and 4 fascicles. And amongst the 2 patients who had 5 fascicle surgeries, the second patient in particular, by 12 to 14 months, showed a much better response. And even the first patient who had 4th month response was better when it was secured to the corneoscleral tunnel. Overall, the patients did improve by 12 months. The 2 patients, the 2 eyes that were followed up beyond 12 months showed a much better response with time. Patients with corneoscleral tunnel showed a faster response. Younger age groups showed a faster response. And there was no difference in the results between contralateral versus ipsilateral sural nerve transplant. This is the confocal microscopy of a patient preoperatively and postoperatively. You can see that there is evident corneal nerve budding by 12 to 24 months. This is a patient who underwent corneal neurotization along with a DALC procedure. Post-op day 1 and post-op day 14, if you compare it with post-op 8 months, you can see the corneal reflex, surface and sheen has definitely improved. This is one of the first patients again who had undergone DALC and corneal neurotization, and it was published. The ASOCT shows the presence of the fascicle, the nerve fascicle bundle in this scleral, in the sclera, and it is well in place. Preoperatively, this patient underwent left eye corneal neurotization. You can see there is no corneal sensations. And now the left eye sensations are going to be checked. The patient blinks, and that is the success of the surgery. So to conclude, I hereby say that corneal neurotization is a very promising procedure with satisfactory outcomes. Corneal transplant and other lid procedures can be combined along with neurotization, and along with the reappearance of corneal sensations, the overall improvement of ocular surface can also be considered as a successful outcome. The only limitation we had was unavailability of a corneal aesthesiometer. Thank you, one and all. First, the corneal surgery was done, sir, and then the neurotization was done. So few patients, it was done in a period of a month's time, and few patients, if there was no improvement, it was checked again, and then neurotization was planned.
Was there any case in which just neurotization was done?
Yes, sir?
Was there any case in which just neurotization was done?
Yes, sir, there were patients, there were patients. And they are improving, sir. They were improving.
And where did you suture the proximal end of the sural nerve?
The proximal end of the sural nerve, either ipsilateral and few cases on the contralateral. So that's ipsilateral versus contralateral, there was not much difference that we observed.
Not much
Not much
and
difference,
why
sir.
did you use a GA for this such? Any
So,
specific reason?
A long procedure, then sural nerve was grafted, and most of the patients were young. So my oculoplasty surgeon. No. Nylon, sir. 10-0 nylons. Yes. Side to end coaptation was done, sir, directly. No, sir. Directly it was.
Okay, so nice presentation.
Thank you, sir.
Dr. Samya.
Thank you, sir.
Is next speaker Dr. Swati Goel here? Dr. Swati Goel. is not.
Dr. Shafina, are you aware that you are not a ratified member? So
I'm not
we will
a
not disqualify. Okay?
We will not be judging you for the best of paper, but you can present. Please go ahead.
Good morning all. I would like to speak about Ispirator, which is an innovation for orbit and oculoplasty surgery. In surgical practice, it is essential to provide a clear and bloodless working field. Hence, a section apparatus are required. Is an important part of surgery. Ophthalmology as a surgical branch involves small quantity of blood loss. Like in cataract surgery, it will be less than 5 ml, and orbital surgery around 75 ml. However, small area of surgery and delicate tissue is a unique challenge in aspiration of blood. Also, there is pooling of blood and fluid in deep socket, and the bleeding is an important, challenge in surgery, especially in orbital surgery, which require deep tissue access. Over years, there are many types of aspiration equipments like angiosterometer, manually operated suction pump, electrical suction pump. But the pressure in these instruments are very high, and also the suction tips are very large, which is difficult to maneuver in the small orbital field. Ispirator, our innovation, is made to solve the problems created by aspiration equipments. It is an easy, do-it-yourself and cost-effective and efficient tool to aspirate small amount of blood in surgical field. It can be made using recyclable and easily available components. It consists of a foot pedal, a DC adapter, a DC water pump, an intravenous set, and collection bottle and a bottle stand. And it works by direct current, which is connected by a adapter, and this adapter is connected to a foot pedal, which acts as a on and off switch. And this foot pedal is connected to a self-priming motor, and to the aspiration end, it is connected to a tube, which is connected to an opening in the collection bottle, and which will create a vacuum inside the collection bottle. And there is another opening on the bottle, which is connected to the IV set, and this IV set is connected to the, it can be, the other end of the IV set can be used in the surgical field for aspiration. So when the foot pedal is on, it will on the motor, which will create vacuum inside the tube, inside the collection bottle, which will aspirate the fluid inside. There's a video, I will play the video in the last. So the advantages are this aspiration is controlled effectively by foot pedal as and when required, unless the conventional aspiration tube, which is always on. And the opening of the drip set is small and flexible, which can be easily maneuvered in small surgical field. And new IV set can be used for each surgery, which will avoid the need for sterilization of the whole equipments for each patients, and it will avoid cross infection. And the entire apparatus can be sterilized by ethylene dioxide sterilization, and it is cost effective because the entire equipment will cost less than 1,500 rupees. And can be used for orbital surgeries like dactyocystorhinostomy, dactyocystectomy, excision biopsy, orbitotomies, and eviscerations. These are my references. I'll play the video of working of the instrument. So this is the adapter, which is connected to the power source, and which is connected to a foot pedal, and this is the motor, which is connected to the collection tube, and this collection tube is a used saline bottle, and from here the IV set is connected, which is going to the surgical space. And we saw that it is clearly aspirating all the blood and giving a clear surgical field, which make the surgery more easy and reduce the time of surgery. The blood is aspirated when the foot pedal is on. Thank you. Yeah.
Did you compare like how much time you consume for aspiration of blood with the
Actually, I'm doing a study comparing it with the normal. It will take less than it will be less than 1,500 the whole equipment. Oh yeah. Yeah, definitely. Thank you.
So thank you, Dr. Shafina, for your presentation. Is Dr. Neelam?
So a very good morning. My topic for this session is lower eyelid blepharoplasty, the effects on the functional epiphora. Can I switch on the slides? Okay, thank you. So I know financial disclosures. As we all know, the lower lid has a major role in the maintaining the blink mechanism and the lacrimal pump mechanism. So any surgery which is involving the lower lid, either it could be a blepharoplasty, lower lid blepharoplasty, we need to maintain the tightening and the laxity of the lid in a very adequate way to get the good functional outcomes. So lower eyelid blepharoplasty, it is being a time-tested technique which usually considered as an aesthetic surgery. It causes a positive changes in the restoration of the aging periorbital tissue concerning the brow and the cheek for a youthful facial look. So while fat and skin excision are still carried out with the current lower lid blepharoplasty, present trend follows a tissue preserving philosophy that may include the orbital and the soup relocation and the fat transposition to restore the apparent volume loss associated with the facial aging. So lower eyelid blepharoplasty, we have the documentation where strengthening procedures when combined like in the form of a saptorrhaphy or tightening of the orbicularis muscle or a lateral canthal tendon and skin yields the favorable functional outcomes. So now when we talk about the SMES, that is the superficial musculoaponeurotic system, which is often described as an organized fibrous network which act as an aponeurotic mask and invest the facial muscle and connect with the dermis. It is uniquely positioned to reflect and respond to the global eye movements. So the concept of SMES is generally accepted in the aesthetic surgeries and is applied to correct the ptosis of the facial fat in areas prone to aging, whereby the SMES is drawn up and fixed to the more superficial muscular and the dermal structures. So the functional epiphora is kind of a subjective symptom of overflow tears, is a major determinant of quality of life. So by keeping all these points into the consideration, we have considered that when we perform a lower lid blepharoplasty with the SMAS and the orbicularis oculi lift, it can alter the horizontal lid vectors with an improved eyelid contour and eyelid tension. Definitely decreases the excessive skin fold and has the lid laxity, and it causes strengthening of the lateral canthal tendon. So it can result in a refined blink mechanism. So with all this, we have formulated a study where we try to assess the effect of the lower lid blepharoplasty with an SMAS and the orbicularis oculi lift on the improvement in functional epiphora and the quality of life parameters. So this study was conducted over a period of 1 year. It was a prospective international study where 18 patients approved by the Research and Ethical Committee underwent the lower lid blepharoplasty in SMAS and orbicularis oculi lift. So at pre-operative and a post-operative assessment was performed at 1 month and 6 months. For the epiphora grading, we have considered the Monk score, the traditional one, and the for quality of life questionnaire, we have considered the validated lacrimal symptom questionnaire. So the authors preferred surgical technique was a transconjunctival approach. However, we also given a transcutaneous incision for the SMAS orbicularis oculi lift. So medial, central, lateral fat pads are fashioned into the 3 fat pedicles which are repositioned or relocated beyond the infraorbital rim into the SOOF area. In order to strengthen the lax orbicularis oculi, the SMAS orbicularis complex is identified and a flap is fashioned which is then lifted and fixed to the inferomedial superficial temporoparietal fascia. So the results were obtained after a 6 months follow-up visit where majority of the patients in terms of the anatomical results have achieved a symmetrical and the adequate lid contour. A high lid slant was observed, however, in the 2 of the eyelids. In terms of the functional results, we have observed a significant decrease in the Monk score in comparison to baseline both at 1 month and 6 months respectively, and a significant improvement in the quality of life parameters at 6 months follow-up visit. So coming on to the discussion, previously the upper lid blepharoplasty have been evaluated and documented, resulted in comparison to the functional epiphora. However, the literature is still lacking and no study have yet performed which have considered and compared the lower lid blepharoplasty in relation to the functional epiphora. So basically this is a surgical technique, so I would like to highlight few of the surgical points which we need to take care to get the good functional outcomes. So why we are given with the both 2 incision, that is a transcutaneous and transconjunctival. Transconjunctival definitely because it provides a better access and repositioning of the fat pads. Plication of the SOOF and suspension of the mid-facial tissue are effective in mid-facial rejuvenation, and same aspect we utilize in our current technique. However, the surface being an elusive entity can only be visualized from the suborbicularis space during a skin muscle flap procedure, and that's why we given a skin incision. The second point is that we need to take care of the critical zone, which contains the terminal twigs of the zygomatic branches of the facial nerve that supply the pretarsal and the preseptal orbicularis oculi muscle. If we are going to damage this, then this may result in the iatrogenic ectropion or weakness of the lower eyelid following a transconjunctival lower blepharoplasty when we combined with the SMAS. The next point is the Clifford ligament. As you all know, it's an arcuate expansion of the Lockwood ligament, and it inserts into the inferolateral orbital ring. So this ligament has a major role in maintaining the lateral support, and that's why it serves to check the inferrectus and inferoblique muscle, and acts as a protective mechanism to prevent the excessive backward displacement of the Lockwood ligament. The fourth point we have kept into consideration, that is the inferior oblique. The inferior oblique usually remains spared very well in the transconjunctival approach. However, when we perform a SMAS orbicularis lift, then aggressive transposition with simultaneous stretch can cause IOM and result in diplopia. So being the small sample size and heterogeneity in terms of excision and repositioning of fat set, these were the limitations of the study. And here I would like to conclude. The lower light blepharoplasty led to alteration in the orbitomolar vectors along with improved eyelid contour and eyelid tension, reduction of the excessive skin fold with lid laxity and strengthening of the lateral canthal ligament, hence result in a refined lacrimal pump mechanism. It acts as a promising technique to reduce the bothersome functional epiphora and improve quality of life. Thank you. Yes, sir. Sir, basically we have any case even with a medial ectropion was ruled out. We have just considered all the cases where we just got a skin laxity in the form of either a medial canthal laxity or horizontal canthal laxity, but without any component of ectropion. If the puncta was opposed, then that is the initiation of the ectropion. Sir, we have performed the basic test for the ectropion. We have done all the laxity test. We have performed the lateral medial canthal. We have done the pinch test also, sir. But I don't think in any of the cases there was a component of ectropion we have considered the patient for the study inclusions. Except this, we have not performed any tests, sir. Yes, sir. Right, sir. Right. Right, sir. Right, sir. Sir, right now, so we just went ahead with the observation at 1 month and 6 months. In future, we can consider this component because definitely the Botox is one of the main utility which we use in advance. Right, sir. But in Botox, sir, definitely the patient will require the frequent 3 to 6 months again and again, and the cost effective is a. Okay, sir. Right, sir.
So, nice presentation, Dr. Deepak. Thank you.
Yeah, thank you very
much. Call upon the next speaker, Dr. Shafina P.
This presentation from Guru Nanak Eye Center. Thank you for AIOS for this opportunity. Patient profile and referral practices for glaucoma. What are the goals which are still unmet? How do I forward it? You have to start the timer again. It forward nahi ho raha isme. Okay. How come there is? If you could just start the timer again, please.
Ma'am, we'll have 30 seconds to continue.
Okay, no problems. So any goal will have good strategies can still fall through the cracks if we don't do a gap analysis. And for this gap analysis in any healthcare system, we need to have studied two players. The two players are the doctor and the patient. And that's exactly what we did with the aim of evaluation of clinical characteristics of cases referred to glaucoma in Guru Nanak Eye Center, New Delhi, a tertiary care medical college, to study both the knowledge and health-seeking behaviors of patients with glaucoma And most important, but not the last but not the least important, would be the referral practices of glaucoma cases with special emphasis on missed angle closure glaucoma. It is a hospital-based observational cross-sectional study, and all the patients coming to the glaucoma clinic, all the primary glaucoma cases were taken. The outcomes were the subtypes and type stages of glaucoma, and the second primary outcome was missed ACG diagnosis or documentation by the first care doctor. Secondary outcome was the patient awareness and knowledge of glaucoma by a self-designed validated questionnaire adapted from Prabhu et al. Duration of symptoms and reasons for delay in presentation. Why were these outcomes taken? Because this is what I've found over last so many years of doing glaucoma practice, that's a problem. So 500 adult patients with primary glaucoma, 60% males, 86% were 7th decade or older, of mixed ethnicity, both Hindus and Muslims. Majority at 43% lacked any formal education. They were coming to the government sector. 74% had no source of income. They were dependent on their children. That's important because in glaucoma, you don't treat just the eye, you treat the patient. There was no health insurance for any at that stage. 85 patients were residents of Delhi. Despite that, Delhi is a wide sprawling city. 73% traveled 10 to 30 kilometers for drug refills. The delay in treatment, seeking treatment of more than 6 months was seen in 41%, and 1 to 6 months was in 48%, which was huge. And this delay was due to ignorance in 62%, no access to nearby health facilities, and mind you, this sitting in Delhi, the capital of India, 36%, and lack of caregiver, the important thing, 22%. This picture shows you exactly what the problem with the caregiver is. Most of these patients are old, and this son-in-law brought the mother-in-law, the son doesn't take care, so I'm going to bring her, and she had come with end-stage glaucoma. The glaucoma subtypes, as expected, POAG was equivalent to PACG, as has been published from our hospital previously. 48% had severe visual defect, legal blindness in 37%. Of all the blind patients, PACG compromised 46%, almost half. 1/4 cases required laser or surgery prior treatment. Now, this is the important thing. 28% had already undergone a prior filtering or a cataract surgery. 62% were on anti-glaucoma medications. On the ACG subtype, only 20% had a prior peripheral iridotomy. 80% were undiagnosed. And most of these PIs were done in our hospital. Referral practices, prior diagnosis of glaucoma was seen only in 20%, despite many of them being on anti-glaucoma medications. Despite a qualified ophthalmologist being the referring physician in 92%, and 28%, as I said before, had a prior ocular surgery, invariably cataract. The criteria for referral to our clinic was high IOP in 60%, dysuspect 39%, poor vision, visual field suspect, gonio suspect was abysmally low at only 5.4%. Gonioscopy had been neither performed nor documented in 80% by the primary care ophthalmologist. And that's a really, really sad situation in India. This is the referral practices. As I said, 92% had been seen by a qualified ophthalmologist. None of them had done a gonioscopy, and they had missed angle closure glaucoma, which in time could have been prevented. Patient awareness was poor at 9.2%, knowledge even less. 95% were ignorant about the cause. Only 8% understood irreversible nature. 5% felt IUL would reverse it. 20% were unaware that after surgery also they would need follow-up. This is our the questionnaire which we designed, and this has been echoed. We are echoing the many studies of Venkataraman et al. From Coimbatore and the Chennai study which says gonioscopy was not performed. Determinants of awareness were occupational, educational status, and disease knowledge, and surprisingly negatively associated with older age and male gender. Poor adherence also was analyzed. Irreversible disease and no perceived benefit, difficulty in using medication, asymptomatic disease in early stages, and hand-eye coordination problem and forgetfulness were the main common cause. So goals still unmet are patients presenting with advanced disease in 48%, delay in treatment results from ignorance, poor access to health facilities, lack of caregiver, despite ACG comprising 50% of hospital glaucoma population. Referral practices or lack on performance of essential gonioscopy was pretty bad, 80%. Awareness was poor at 9%. Education and lack of disease were identified as a key things. So our learning was education is required, perspective, surgical option, exercise early. Many patients depend on free medications, do rational therapy. And again, in the gap analysis, we started doing a gonioscopy and perimetry workshop in our hospital, successfully 2 done over the last 2 years, and our counseling practices. Thanks to my glaucoma team.
So the next session people can take over. Meanwhile, ma'am, can you suggest a simpler technique? 92% don't do gonioscopic maybe because they don't have time or they don't know the technique. So like the antechamber.
You have every company has, sir. Philips has. As Zoll are the king. Every vendor who are supplying the defibrillators, they also supply the AED. But nowadays, apart in the defibrillator, I told you they are also keeping the AED mode because it may be used by a skilled man who knows everything about ECG, used by a person who doesn't know anything about the ECG. So AED mode is also there in the defibrillator also. But pardon? 2 in 1. Yeah, 2 in 1. That is it, not 2 in 1, 3 in 1. Because monitor is also there. The monitor is also there. You can see the monitor, attach the pulse oximeter.
Dear colleagues, so this is my paper on innovative IOL, which is a rigid IOL, which is focal in nature. So cataract is does not look at anybody as to whether the patient is able to afford or not able to afford for multifocality. Sorry, I'm not able to get this. My slides are just moving on its own. So this is my financial disclosure. So this lens is developed by the entrepreneurs, Dr. Ramesh C. Shah from Borivali, Mumbai, Dr. Jagdeep Kakadia, and Dr. Vikrant Bhale of Lifeline Medical Devices. So this IOL was developed with intention of having both near, intermediate and far distance vision for the patient without the use of principles of refraction and diffraction gratings. So there are no rings. That's how we will be able to prevent the incidence of halos and negative and positive dysphotopsias. So every patient is entitled to have a multifocal vision because cataract doesn't see at anybody whether he is able to afford or not. But most of these multifocal IOLs are manufactured in foldable form and with so many disadvantages. So this is how the vision is seen in this polyfocal IOL with no evidence of positive or negative dysphotopsia. So this was developed on a technique called DIN, where we have distance, intermediate and near by green technology, that is gradient refractive index. Just like a progressive glass that we wear externally, this IOL has been developed in a polyfocal zone where a progressive zone is made from the center towards the periphery. So there's no loss of light energy also. This is a large IOL, about 7 millimeters in size, the optic size. So this being a rigid PMMA, so this will be the first ever lens of a progressive lens, so-called progressive lens, which we call it as a autofocus lens, because we call progressive as a misnomer, where you have got diffractive and refractive gradient causing where the rings are present. So we did a study of a sample size of 40 eyes of 34 patients with 22 males and 12 females. We excluded the patients with corneal opacity, retinal disorders and optic atrophy. And all the surgeries were performed with a 6.5 mm sclerocorneal tunnel, and the incisions were taken on the steep meridian to set right the astigmatism, pre-existing astigmatism, up to 1.5 diopters also. And these were the results that we got. So it is 612 to 66, and near vision was N8 and N6. No PC was noted in any of these cases because the large sized IOL, and it used to say have a full touch with the posterior capsule, and the mean follow-up was about 16 months. So this is the results of these IOLs, both the eyes in 18 months post-op follow-up. And this being a large-sized optic, it does not interfere in any of the retinal procedures like laser photocoagulation in diabetics, and there is no double or triple diffraction of green laser spot if at all they need PRP in future. And this will be advantageous for people using for the indirect ophthalmoscopy for examination of the retina for treatment and surgery. And this is the IOL that is now going to be commercially promoted. We call it as $1 million optics, and the brand name is Solitaire. So these are the specifications with an optical A constant of 118.71 or 118.53. So the lens has advantages of no posterior dysphotopsias, no glare, no halos, no waxy vision, photic phenomena, and we want to make it affordable to all the population, where the expensive foldable multifocal IOLs are the norm in the present day. In most cases, we had vision of 6x6 or better, and unaided vision of N6 at 12 to 14 inches. The patient was comfortable with computer vision with excellent from 2 to 4 feet, and women who were working on the kitchen platform had better vision for working, and even the patients who were needing work for, say, threading the needle in low light, even after bilateral surgery, this was advantageous. So the patient has very quick adaptation. Even if the patient has been implanted with a monofocal IOL in other eye, so this IOL can be implanted in other eye also. We haven't tried it in a patient with a multifocal IOL in the other eye. So I feel that this is everybody's birthright, because cataract does not know whether the patient can afford or not afford for a multifocal IOL. So this is going to be cost effective for the large population. Thank you for the patient hearing.
Now that most of the surgeries are converted to phacoemulsification, do you all intend to make a foldable one also on this lab?
No, so foldable is already made, and we have already commercialized it. So about 65 doctors who have invested in this company, and the foldable IOLs is made in a copolymer platform, and also the hydrophobic IOLs are going to come in future. So this is basically for an unaffordable population who are not able to afford the cost of the multifocal IOL at present. This would be costing between 1,500 to 2,000 rupees now.
A very good morning to one and all. So I'll be presenting the topic on effectiveness and future implications of COVID-related risk stratification in managing retinopathy of prematurity, the Indian Twin City report number 10. So these are my affiliations. I have no financial interest. So as we know, the COVID wave hit us like a tsunami wave in 2020, with most of the essential services were closed, but ROP was a very important essential service that needed utmost importance, and it is a time-bound disease, so we could not halt this, and it has to be in progress. So the Indian ROP Society came with a set of guidelines. It included both the safety guidelines as well as the risk stratification guidelines. So we kind of validated these Indian ROP Society guidelines to see how effective this is. So The safety guidelines, as we know, here is the proper hand hygiene or sanitization, or see the quarantine stamp of the parents, and also the face masks and other proper COVID gear. And the risk stratification guidelines, where the Indian ROP Society divided the babies into high risk and low risk. Low risk are the ones, babies which are systemically stable, which have good weight gain, and who are above 34 weeks of postmenstrual age, and who are more than 1,000 grams of birth weight. So in low risk babies, we kind of try to reduce the frequency of follow-up, because we have limited resource during COVID, and give the maximum outcome and make sure none of the babies went into retinal detachment. Whereas the high risk babies, the very low birth weight and other babies, we followed the old guidelines itself. So we strengthened our outreach services. So we can see, out of the 200 babies screened during the first wave of COVID, the majority of 143 babies were from the outreach hospitals in and around Hyderabad, whereas 57 were from the Apex Center. So let us see some of the safety guidelines that we followed. So here we can see the mother will place the baby in the cradle, and we do not want any of the sisters or mothers to overcrowd there. We ask the mother to step behind, and only the doctor screens. The doctor screens the baby under the radiant warmer, connecting all the monitors. And with this, you know, we can reduce the transmission of COVID to mother or the sisters or the doctor, or the transmission to the baby itself. So we do not want too much of crowding to happen. This is in a very stable babies that come to our OPD. So if the babies were much more sick babies, or which babies in NICU, we use these acrylic boxes to screen the babies. So we can see these are acrylic boxes which have hands, you know, these kind of protect the babies from this COVID transmission from the doctor or any other attendant who are nearby. And it has a nice hand holes to where we can easily screen these babies. So by this we can reduce the COVID transmission to the babies, as well as the parents or the sisters, and also the doctors. So these were the safety guidelines that we took into account. So what are the stratification guidelines? So I said these stratification guidelines were followed only low risk babies. So low risk babies with very mild ROP, we kind of reduce the follow-up, or we extend the follow-up by 1 week. That is, if it is zone 2 anterior or zone 3, we kind of reduce the follow-up by 1 week. That is, we postponed the follow-up by 1 week. Whereas if the baby was pre-plus, and if pre-plus babies we treated early, because pre-plus babies, there are high chance of them losing to follow-up if you call them in the next week. So we treated the pre-plus early, because the apprehension of the parents to reach the hospital, or if they miss the follow-up. So anticipating this, we treated the pre-plus early, whereas very mild ROP, we follow-up, we reduce by 1 week. And if the babies had you know, AP-ROP, which needed immediate anti-VEGF injection, then we gave the anti-VEGF injection on the same day, and we followed this baby by teleconsult. So we did not want to call the baby after 1 day to check whether the baby has endophthalmitis or not. This follow-up can be reduced by doing teleconsult, where the parents will, or the NICU neonatologist will send the WhatsApp image or the email with these baby photos. So if at all baby has lid edema or congestion, that will alarm the treating doctor that the baby has endophthalmitis. Then only we call them to the clinic. Same for the even the surgically treated stage 4A or stage 4B ROP also, we kind of reduce the follow-up by teleconsult. So we found out that in our study, that with this new validation of the IROP Society risk stratification, that none of the babies with no detachment went for detachment. So this is no way a suboptimal. This is a calculated risk that was taken in low risk babies to reduce the number of frequency and the transmission of COVID. So we found out that none of the babies went for detachment. So the new risk stratification is no way suboptimal. It can be easily, it's a calculated risk that is taken in low risk. And of course the risk stratification and the COVID safety guidelines, both in terms of reducing the frequency of follow-up, is important. So we found out all these, not just the doctors, even the neonatologists, nurses, technicians, drivers, housekeeping and security staff all played a hand in role. We might have forgotten this now, but during the pandemic, it was very important that teamwork and coordination did the work for us. Thank you.
Thank you very much to AIUS for and the judges for bearing with me. Can I have my paper, please? Do we have a pointer? Pointer? No pointer? Okay. Can you start? No, this is not it. This is Kirti Khoka. Kirti Singh, abhi diya na gaps. Free paper, I think it's 6-3. I just gave it to you. So it's a pleasure to present.
इसके पहले वाला फोल्डर
ये आपने अगला वाला शुरू कर दिया है शायद.
उसके ऊपर वाला
glaucoma using an offline AI deployed on a smartphone based fundus camera against specialist diagnosis using gold standard slit lamp biomicroscopy. So this was a prospective cross-sectional study done between June 2022 to December 2022 with the 56% being male, and the mean average population was 53.27 years, and the major outcome, first outcome, was diagnostic accuracy of this AI against the glaucoma specialist. And we took we refer by referable glaucoma, we mean both definite glaucoma and DIS suspects. So a sample size of 200 patients was calculated such that the measured rate of discordance in referable glaucoma between the AI and the glaucoma specialist would differ from the true rate of discordance by less than 8%, which is normally 10 to 50%, and the sensitivity should be of at least 80%. An equal distribution of glaucoma, DIS suspects, and no glaucoma was aimed at between these 200 patients. We included all patients above 18 years who were willing to give consent, and we had a glaucoma group, a normal control group, DIS suspect group, and we took fields which were reliable with the false positive and false negative of less than 20%. We excluded all patients who had acute conditions where narrow angles where dilatation was contraindicated, retinal pathologies precluding the view of the disc, or any media opacity cataract grade more than nuclear sclerosis grade 3 was excluded, and also participants who were in the opinion of the investigator who would prelude the participation in the study, like uncontrolled intraocular pressure, active infection less than 3 months post glaucoma filtering surgery, and also those in whom the imaging was contraindicated where the patient was hypersensitive to light or recently underwent photodynamic therapy. So this is a flow chart. We had 3 groups: normal, DIS suspects, and known case of glaucoma. They all underwent vision testing on Snellen's chart, and then an undilated fundus photo was taken by the Remedio fundus on phone camera. If the image sufficient, if the quality of the image was sufficient, the AI was run on the image, and the AI interpretation and the VCDR was noted. And if the image quality was not sufficient, 2 attempts were needed, were again given to the optometrist or the MLOP to take a sufficient quality. Again, if it is not coming of sufficient quality, then the patient was dilated after all these preliminary testing like IOP, gonioscopy, visual field testing, and then pupillary dilatation, and then after dilatation, grading of the cataract and dilated fundus photo was taken, followed by OCT. Again, the AI was run for interpretation only on those cases where the undilated image was not good enough. So, and then all the findings were noted, and then finally these patients were given to a glaucoma specialist who was masked to whether this patient is a part of the study or not. So as we were doing normally, how we see a glaucoma patient or a DIS suspect or a normal, we did that. Wherever required, we did HFA and OCT. So these are the results. According to glaucoma specialists, there were 94 plus 55 referable glaucoma, which includes glaucoma and DIS suspects. And according to AI, it was only true positives were 128. Glaucoma specialists gave 149 as referable glaucoma, and according to AI it was 128. So the sensitivity or the true positivity was 85.9%. For no referable glaucoma, according to the specialist there were 66, and according to AI the true negatives were 64. The specificity was 97%. So the sensitivity was 85.9, specificity was 97%, positive predictive value was 98.5, and negative predictive value was 75.3. So sensitivity and specificity was high, and it was like it was comparable to the specialist diagnosis, and AI showed robust performance in detecting referable glaucoma with minimal overcall of normal cases. So to conclude, novel AI integrated on a portable fundus camera can have a significant impact in screening for preferable glaucoma. It can be implemented in population-based or vision center-based model by minimally trained personnel. It can be a support tool for ophthalmologists through timely referral, especially in resource-constrained environments, and it has the potential to make glaucoma screening accessible, affordable, and effective. The limitations of our study was AI was evaluated only in Indian population, so generalizability across the populations is to be determined, and performance evaluation based on severity of glaucoma has not been done, so it has to be done in the future. Practical implications: Remedio fundus on phone with offline AI for glaucoma can be used for mass screening at remote places, schools, community halls, and workplaces, and AI can help in reducing unnecessary referrals. Thank you.
Can you please start once again?
Can I start, sir? Yeah. Good morning, judges. So I'll be presenting my paper on cerebral visual impairment, our perspective. CVI has become the leading cause of bilateral visual impairment in the Western world. And in India, its prevalence has increased in children less than 3 years of age, and it has exceeded the cause of congenital cataract and ROP, and has become a significant public health problem. Any damage to the visual processing area causes cortical visual impairment. It comprises of visual malfunction due to retrochiasmal visual and visual association pathway pathology. It can be seen isolated, or it can accompany anterior visual pathway dysfunction. So the aim of our study was to understand the causes, the radiological features, the prognosticating factors, and impact of timely visual rehabilitation. So it was a prospective study done between Jan 2012 to December 2022. Patients included were children who did not, in whom the ophthalmological findings did not explain the visual performance. There was history suggestive of a stormy perinatal period and associated neurological pathology. So all children underwent a thorough evaluation, including a detailed history, age-appropriate vision assessment, keeping the cognitive ability of the child in mind. MEM retinoscopy was done to look for the accommodation insufficiency. Intraocular pressure assessment was done. Squint and ocular motility assessment was done. They underwent cycloplegic refraction. Anterior and posterior segment was evaluated. Pediatric neurology opinion was taken and underwent neuroimaging. And finally, all the patients were counseled parents were counseled regarding the child's condition. So all children were advised to review after 3 days with the required optical correction for functional vision assessment and planning of the vision training strategies. Children who had ocular visual impairment were treated with adequate measures wherever indicated. We had 199 children, of which majority were boys. The commonest mode of delivery was normal, and we had 87% who were term delivered. The age range was 1.5 months to 216 months with a mean age of 34.5 months. Almost 70% were less than 3 years of age and 40% were less than 1 year of age, and majority of the children were referred to us by the pediatrician and the pediatric neurologist. The functional vision impairment was classified into 7 levels, with 0 being no perception of light, and level 1 to 6 based upon the Hoyts et al. Classification. 1 is perception of light ranging to 6, which is normal visual acuity. Accommodation insufficiency was seen in 5% children. The commonest refractive error in our cohort was compound hyperopic astigmatism, which was seen in 35% children. Exotropia was seen in almost 62% patient, 20% had nystagmus, and more than 50% had optic dyspallor. CVI with ocular visual impairment was seen in 76% children. Of this, 79% children underwent vision training. The commonest cause in our cohort was perinatal brain injury, followed by hypoglycemic brain injury. And the commonest neurological abnormality was global developmental delay, followed by seizures, cerebral palsy, microcephaly. And the associated anomaly, the commonest was congenital heart disease. On neuroimaging, the commonest feature seen was hypoxic ischemic encephalopathy and periventricular leukomalacia, followed by parieto-occipital gliosis. So after visual training, we noticed that almost 11.5% children were high functioning, whereas the rest were low functioning. Of 199 children, 79% underwent visual training, 66 came for follow-up, and there was 1 or 2 level improvement seen in almost 35% children. However, 21% failed to review. So we know that occipital lobe is where the major information comes, and from there the higher visual processing takes place en route to the frontal lobe. The occipitotemporal pathway is responsible for the recognition of object, and occipitoparietal pathway is responsible for spatial processing. The spectrum of CVI can range from very low functioning to very high functioning. The most common cause in the series was HI, which is in accordance with the other studies done in India. 70% children were less than 3 years of age, and this first 3 years are very crucial for the child's overall development. Majority of children were referred, so we know that there is a role of pediatrician and pediatric neurologists in identifying these children and timely referral to us. 48% had very low vision ranging from no PL to PL, and this highlights the implication this condition can have in declining the overall child's development. The commonest refractive error was compound hyperopic astigmatism. This pallor was seen in more than half of the children, but it was not associated with any other ocular cause, so the likely cause here is retrograde degeneration. 5 children had bilateral visually significant cataract who underwent surgery. HIE was a commonest etiology, and GD was a commonest neurological manifestation. Abnormalities on neuroimaging were seen in 97% children. So we had almost 11.5 high functioning CVI. These children go to regular school and often have normal visual acuity, but they can have issues with learning difficulty, decreased scholastic performance, and trouble in sports and socializing. These children are often missed in the regular OPD because of better visual function, but clues in the birth history and asking leading questions about the scholastic performance could help. 21%, despite being diagnosed, they did not undergo vision training because the parents failed to follow up. Many patients were also lost to follow up as they belong to other states and hail from a different country. So establishing easily accessible CVI centers across the country could help. So we believe that a thorough CVI assessment at least once could help initiate a therapy, create awareness to the caregivers, and improve quality of vision and promote better follow-up. So I would like to conclude that an emergent need for a comprehensive eye evaluation in any child who has a stormy perinatal period. It requires a multidisciplinary team. Timely intervention for correcting the treatable ocular causes is a must. Creating awareness in the community is the need, and providing various therapies at economical rate under one roof is very, very important in bridging the gap in this predicament. Thank you. Ma'am, the whole idea behind presenting this paper was like everybody talks about the causes, but nobody actually talks about how many children actually end up coming to you for subsequent follow-ups. So the stress was upon this, that we should also highlight how we can encourage these parents, counsel them, and make sure that they come for regular follow-ups. As I mentioned, as you must have seen, the study is over a period of 10 years. So in children with CVI, you won't ever see instant improvement in the vision. So you have to follow these children over a period of decades to actually see whether they have improvement. And even one level improvement makes a big difference to the child's life. So the idea is to promote a message that we have to start creating awareness. Don't miss out these children. Some may appear to be normal, but there could be certain clues. So taking a detailed history definitely helps. And if you're seeing any children who has a stormy perinatal period, the first 3 months of life only we should make sure that they undergo a eye evaluation, and preferably with a pediatric ophthalmologist, because they would be able to catch these children early on. And yeah, but some of what I've seen is they are the ones who are actually referring. So yeah, in the pediatric neurology. Yes, absolutely. Thank you so much, ma'am. Thank you.
Respected chairpersons and my dear colleague, I will be speaking on multimodal strategies for public awareness in diabetic retinopathy. As we know, a successful program to combat diabetic retinopathy in part relies upon the level of awareness about diabetes in the community. It appears that awareness of diabetes and diabetic retinopathy is relatively low in many parts of India, making it difficult to engage in preventive actions, diagnosis or treatment. In a study done in southern India, it was found that awareness that diabetes can cause diabetic retinopathy was present in only 28.8% of the urban population. The aim of our study was to find out the best possible method for increasing the level of awareness in the community about diabetic retinopathy, screening and treatment. In this study, all the screening and treatment programs camps organized between November 2009 to December 2012 were included. All the camps were organized in the Bagpat district of the Uttar Pradesh. On the day of surgery, a team comprising retina specialists, optometrists and other team members will go to the venue in a mobile van equipped with portable angiography and laser machine. All the patients requiring angiography and laser were done there itself. As we know, there are three main approaches for any public education program. When a large section of the community is approached, it is known as the mass approach. When a specific group is targeted, it is known as the group approach. And when a specific individual approach, it is known as the individual approach. In mass approach, we have poster depicting the effects of diabetes on the various organs and their prevention. And the posters for the awareness of diabetic retinopathy, they are intended to raise general awareness, and they are contain illustrations depicting the effect of diabetes and retinopathy on the retina. In the similar way, we can make some calendars which can be put on the various places. A small pocket calendars providing regular encouragement for diabetic retinopathy were also made. The main purpose of organizing press meetings is to disseminate knowledge about the diabetic retinopathy with various articles in the newspapers. Awareness can also be
यदि आपको शुगर है तो आपको अपनी आँखों की जांच हर 6 महीने में
these awareness campaigns by celebrities can also be done, and by awareness campaigns in the FM radio.
यदि आपको शुगर है तो आपको अपनी
Coming to the group approach, various seminars and lectures can be organized. This main purpose of seminar is to engage the physicians and diabetologists, so can they, and also the local health workers and medical personnel. In these circulars were distributed, which contains the basic information about the effect of diabetic retinopathy with various stages, and the ideal follow-up schedule was included in that. By celebrating special World Diabetes days like World Diabetes Day in schools and etc., a large section of the community was approached, which in turn provided the large section of the community was approached. Patient intersection were held at the campsite, followed by a short presentation and a question and answer sessions. We can also make pamphlets which contains in the vernacular language containing the basic information and stressing the importance of early detection and brief information about the diagnosis and treatment of diabetic retinopathy. Individual counseling sessions were also held, which provide a perfect opportunity for one-to-one interaction. In our experience, we found that all these approaches are useful in urban and semi-urban areas, but were less useful in rural areas, because people vary so widely in their socio-economic conditions, tradition, attitudes, and belief that a mixture of different approaches are required. As we've seen in the camp, that when we give some pamphlets to the patient go outside and he throws the pamphlet. Most of the patients who come these camps, their motive is to get a free eye drop. So we developed an educational movie to impart knowledge about retinopathy, covering all the aspects of diabetes and retinopathy, in which a protagonist who is a diabetic and is based in rural area is repeated counsel as is irregular in treatment and follow. भी नहीं दिखाई दे रहा है, ठीक है? अभी आप बाद में देखिएगा, उस जगह पे ध्यान से देखते रहिएगा, उस जगह पे सफेदी सी आएगी, दिख रहा है आपको? हाँ जी, हाँ जी, हाँ जी। ये बेसिकली लीकेज है, इसी को हम टेस्ट इसलिए देखने के लिए करते हैं कि on the first follow-up, angiography and laser procedure was shown so as to allay the patient's picture. Importance of the follow-up was also emphasized. A sensitive topic was elusive leaders.
कहाँ फिर रहा है? राम राम बाबा, राम राम। खुश रहो, आनंद करते रहो। और बाबा, कहाँ फिर रहा है भाई? कहाँ गया था? बाबा दिल्ली से आ रहा हूँ। काहे के लिए? बस आँखों को दिखाने गया था बाबा। अरे आप वही
The movie ends in the positive note.
लापरवाही की
the protagonist learns from his mistake and in turn takes upon himself to educate the fellow villagers. In our study, total 22,540 patients were examined. Initially, there were 45. After these 45 camps, they were done with the conventional approach, and the next 95 camps in the movie approach was used. So our results showed that a new approach of movie showed approximately significant increase in diabetic patients and 17% increase in the patients opting for the laser treatment. Diabetic retinopathy is a major cause of blindness with public health implication in India. Prevalence of diabetic retinopathy in South India among a patient over 50 years was found to be 1.3% in one study and who is going to increase exponentially in the coming decades. In conclusion, I will like to say that people vary so widely in their social conditions, tradition, belief and level of knowledge that uniform communication approach is not viable. A mixture of different approaches must be developed depending upon the local circumstances, and we have to constantly evolve new methods of screening and awareness. Thank you for your patience here. Sir, as I said in my talk that you cannot say a particular method for a particular area. Depending upon the level of the knowledge and the awareness in the community, we have to devise new methods, and a mixture of approaches needed in the different places.
So what was different that you did in your usual diagnostic screening and awareness programs?
Sir, we followed the conventional approaches in the first few camps. We could not get the desired results. So we got the idea of making this kind of a documentary drama in that area only. And there is a 45 minutes movie, and I've just shown the clips. And this movie was shown in the local area, in the small cable network and in the small theaters. So it was an interesting movie. The patient also got the message from them, and they well, more receptive for the
local radio for the local population in
yes.
their language.
Yes.
You said it correctly that most of the camps they come for free eye drops and
Do we have Dr. R.C. Singh till now? Move ahead.
Good morning everyone. Myself Dr. Ghazal Patnaik, and I shall be presenting our work on preferred practice pattern in both Koyanagi-Harada VKH disease and Indian survey. So what was the need of this survey? VKH is an old age disease since 1900s, but there exist dilemmas at every strata. Like starting from diagnosis, there is dilemma whether it evolved from Segura's criteria, which relied mostly on CSF pleocytosis, but it was invasive. So it went ahead to American Society of Uveitis criteria. They involved fundus fluorescein angiography in the diagnosis. However, over the years, it was failing to distinguish between an acute and a chronic disease. So then comes revised diagnostic criteria, but it also failed to distinguish between inactive and active, but it is currently the most used criteria to diagnose VKH. So the dilemmas started from diagnosis to imaging, where the place of fundus fluorescein angiography, OCT, ICG, indocyanine green angiography, as well as recently OCT angiography has been evaluated to play very important role at every stage of the disease. Coming to the management, there is a debate whether to have an initial oral corticosteroid or to have an earlier immunomodulatory therapy, whether to institute the immunomodulatory therapy within 3 months, or we can even start the immunomodulation as the first line for VKH. Coming to complications, we are most aware of that. The ocular complications is mostly cystoid macular edema. However, from the Indian studies, only 2 studies that has evaluated that the most common is choroidal neovascular membrane. So we desire that the patient ends up without any complication, maybe like this, having Dallen-Fuchs nodules, but mostly nowadays the complications are getting higher with subretinal fibrosis, exudative retinal detachment, even CNVM. So there was the need, and we aim to analyze the preferred practice pattern for managing a case of VKH, and we did an online survey from September 2021 to February 2022 amongst the Uveitis Society of India. So what we saw that there is a discrepancy between the VKH category being viewed by different groups, and we divided the groups as per the specialist years. That is, the uveitis specialist having 0 to 10 years of specialization were group A, 15 to 20 were group B, and more than 20 years was group C.
and around 17 people did not reveal their information about the practice of years. So we compared the leakage category encountered by them, the most common ocular feature and extraocular feature, which was quite similar in all the groups. However, the images preference to differentiate between leakage and CSR, it varied from FFA, OCT and B-scan as per the numbers. But if you see, it is common almost in all the groups, be it acute, recurrent or chronic convalescent stage. Due to constraints of time, I would be skipping the details. But when we come to the management practice, the duration of oral corticosteroids, there is a huge discrepancy between the earlier group and the group with more than 20 years of experience. The more than 20 years of experience, they preferred a 6 months of oral corticosteroid, whereas the younger one preferred 3 to 6 months of oral corticosteroids. Whereas coming to the immunomodulatory therapy, it was quite common, but there is a split amongst the younger individuals. Consideration of biologic is very recent. However, they do consider after 3 to 4 recurrent cases in all the 3 groups. Complication, however, if we see, they notice macular edema earlier in the course, where it shifts to sunset glow fundus and exudative retina when it comes to younger older experiences. COVID and just changes as the recent parameter, we analyzed that also, but there was no change, and there was a consideration that all the groups had a similar view. So to discuss, when we compared all the parameters between those with a less than 20 years and more than 20 years, we saw the form also changes. Probable is only the ocular manifestation, and more than 20 is incomplete. So over the year, the disease also progresses. What is more important here is the complication. As we see, the complication rate of the sunset glow, it decreases with the group. And to highlight here whether this could be highlighted to the duration of oral corticosteroids or the immunomodulatory therapy, as they also have a discrepancy. So to conclude, many discrepancy prevails, especially regarding the management protocol. With the growing use of immunomodulatory therapy and the newer biologic agents, it is a requirement not only to standardize the diagnostic criteria, but also to standardize the management pattern, so we can deal this dreaded disease and reduce the complication rate as it affects the middle-aged incoming people. Thank you. So I do like no financial interest, obviously.
It's mandatory that your second slide should be that.
Okay.
And just a piece of advice, don't mention your institute in your slide.
Okay.
It's supposed to be masked. However, seeing your co-author, we know where you're from.
Yes, ma'am. As I have discussed in the slides also, that younger populations, the discrepancy between the younger and the one with more experience is mainly the management. The younger prefers 3 months of oral corticosteroids and 1 to 2 years of immunomodulatory therapy, whereas the more experienced uveitis specialists, they preferred 6 months of initial corticosteroids along with an early institution of immunomodulatory therapy. And when we saw the complication rate encountered by them, the complication encountered by the uveitis specialists with more experience is lesser and less dreadful as compared to the those experienced by the younger. So maybe it, yes, ma'am, that's what the prognosis was encountered, because this is an online questionnaire, so the exact visual acuity cannot be attained. We performed the questionnaire regarding the visual prognosis, so they gave the prognosis.
So good morning, one and all. One sec. Good morning, one and all. I have no financial interest, no conflict of interest. So
Rogers. So we all know that artificial intelligence is a booming topic, and we wanted to see whether we can incorporate this in keratoconus and its progression and other associated factors. So coming to risk factors, we know that there are a number of publications which give us a number of risk factors for keratoconus, and we also have published our own 5-point nomograph, which indicates that age, eye rubbing, atopic eye disease, frequent change of glasses, and other factors play an important role in the progression of keratoconus. So we wanted to come and say that can we do a risk stratification in these patients? Can we find out what is the most significant factor that leads to the progression of keratoconus? So we've already published a paper where we use artificial intelligence and the topographic features to indicate whether few patients are either progressors or non-progressors depending upon the K-max of the patient. So we saw that there were between two visits, which are 6 months apart, if there was an increase in one diopter of K-max, that we call them as progressors. So our artificial intelligence model could easily detect this. So next we wanted to see if we can amalgamate this with other high-risk factors and demographic factors. So we wanted to create an artificial intelligence model where we were able to process multiple data and we could easily come and give future outcomes of that patient. So this is my materials and methods. After ethics committee approval, we recruited 500 eyes, and it was a prospective observational study. All the catatonic patients had 2 visits, which were 6 months apart. The first AI model, as I said, indicated whether the patient was a progressor or a non-progressor on the topographic features. And our second AI model aimed at analyzing these with the demographic factors and risk factors. So we went ahead and asked all of these patients a very vigorous data. This was our questionnaire, and you can see that there are multiple data which were asked to the patient. Also, it included the laboratory investigations like vitamin D levels, B12 levels, and the IgE levels. So this was our model, wherein we took this was our model wherein it took progress. So you can see that there's a branching pattern, and this took a number of parameters like vitamin D, IgE, and everything, and it gave us data where we could stratify these risk factors. So we saw that IgE was the highest risk factor, which told us that most of our patients who were progressors had a high level of IgE. The second was systemic allergy, and so on. And our model also predicted that on topographic factors, when there were 74% were predicted as progressors, our second AI model with demographic factors and risk factors also showed that they were progressors. And similarly, in stable patients, 70% of them were indicated as progressors on topographic features. And our second AI model, which included risk factors and demographic factors, also said the same. So coming to the discussion, so we added topographic factors, high-risk factors, and the demographic data, and our most important outcome was the risk stratification. So we monitored the serum IgE levels, vitamin D levels, and systemic allergy in all of these patients. So how do we bring this to the clinics? We saw a 14-year-old girl with keratoconus, and because of our AI models, we predicted what could be the highest risk factors in this patient. So we asked for those blood investigations. The blood reports indicated that she had a very high level of serum IgE and vitamin D levels were low. And there were signs of systemic allergy as well from our demographic data, and she had a history of frequent eye rubbing. So we referred this patient to an immunologist and a physician to alleviate these risk factors, and because of that we saw that she was stable over the next 6 months. So what we already know is that topographic parameters definitely help us detect the progression of keratoconus, and demographic risk factors are also been given, but there has never been a risk stratification in this field. So we came across with the first AI-based model to determine and integrate these demographic and risk factors for progression, and the importance of risk stratification and profiling of the patients, which helps in indicating the disease progression. Thank you. So we wanted to bring about the risk stratification, ma'am. So we wanted to see what is the most important risk factor that helps in indicating whether this patient can go in for progression or not. Yes. Thank you so much, ma'am.
So, unique and cost-effective organism-based endophthalmitis prophylaxis in community eye care section. So, the aim of the study was to analyze the outcomes of different endophthalmitis prophylactic measures in cataract surgery between the years 2013 and 2021 in a community eye care section of a tertiary eye care hospital. This was a single-center retrospective study. So, all the patients who underwent cataract surgery in the community eye care section from 2013 to 2021 were included in the study. Combined procedures such as trabeculectomy or penetrating keratoplasty with cataract surgery were excluded. The data was obtained from the patient records. All patients underwent detailed eye examination with an AK as well as A scan preoperatively, and sac syringing was done whenever indicated. Preoperatively, the periocular area and conjunctival sac was prepared using topical povidone iodine solution, and majority of the cases were done using manual SICS, which is 85.1%, and the rest by phacoemulsification with implantation of a PMMA IOL. The surgeries were performed by consultants, registrars, fellows, as well as postgraduate residents, and the same sterilization techniques were adopted throughout the entire study. So, from 2013 to 2015, the endophthalmitis prophylactic measure which was followed was tobramycin 0.1 ml in 500 milligrams of BSS. In 2015 to 2017, intracameral preservative-free moxifloxacin was used. From 2017 to 2021, 0.1 ml of amikacin 12.5%, which was added to every 500 milligrams of BSS, was used, thereby achieving an effective concentration of 0.025%. So here, the dose of amikacin was based on calculations, which was targeting an anterior chamber concentration of amikacin that would exceed the MIC of the susceptible bacteria. Here you can see 0.1 of amikacin withdrawn and injected into the 500 ml of BSS. So post-operatively on POD1, the eye patch was removed and replaced with goggles. A complete examination was done and patients were started on ofloxacin dexamethasone, which was tapered over 50 days. So we analyzed the records of patients diagnosed with post-operative endophthalmitis or sectional wound infiltrates presenting up to 8 weeks post-operatively. All patients underwent detailed microbiological examination. Statistics was done using the chi-square test. So coming on to the results, we divided them into 3 groups. The first group, which is a tobramycin group, around 15 cases of endophthalmitis were reported. The second being the moxifloxacin group, around 17 cases of endophthalmitis were reported. And the third one being the BSS with the amikacin group, around 10 cases of endophthalmitis was reported. A total overall of around 240,000 cataract surgeries were performed during the study period. So among the tobramycin group, among the 70,000 cases, 15 cases had post-operative endophthalmitis, where majority was culture negative, followed by gram-positive cocci, nocardia, as well as fungal infections. In intracameral moxifloxacin group, 17 cases of post-op endophthalmitis were reported. Majority again was culture negative, followed by gram-positive cocci as well as nocardia. Third, was in the amikacin and BSS group, though 113,000 surgeries were performed, only 10 cases of post-operative endophthalmitis were reported, and culture negativity was 80%, followed by gram-positive cocci. So on comparison between the endophthalmitis rate of 3 groups, after introduction of amikacin, there was a significant reduction in the rate of endophthalmitis. Here you can see the p-value which is being significant on comparing the amikacin group with the toba group, as well as I'm comparing the amikacin group with the moxifloxacin group. Coming on to the microbiological analysis, there was no significant difference in the rates of culture negative or gram-positive cocci among the 3 groups. However, there was a significant reduction in nocardia endophthalmitis in group 3 on comparison with the other groups. So here you can see gram stain, the beaded pattern on gram stain for nocardia, as well as sectional wound infiltrates with hyperpion seen in these post-op patients. So among the endophthalmitis cases, 14 cases had been performed by consultants and 14 each by residents and fellows, and only 1 of the 42 cases had undergone phacoemulsification and rest by scleral MSICS, and only 2 of the 43 cases of endophthalmitis had intraoperative complications, one being PCR and the other being a ZD with vitreous loss. Coming on to discussion, we all know the landmark study, which is the EVIAS study, which stated that gram-positive cocci was the most common organism. Lundstrom et al. Also did a comparative analysis and found that gram-positive bacteria are more common when there was a communication with the vitreous, and gram-negative was more common in elderly patients. So keeping all this into consideration, the EACRS put down a guidelines of saying use intracameral cefuroxime 1 milligram in 0.1 ml. However, then we had the landmark trial by Haripriya et al., where they showed that the use of intracameral moxifloxacin brought down the endophthalmitis rate by almost fourfold. But moving on to the literature review and seeing the causative organisms of endophthalmitis in India, you can see that the slow shift from gram-positive cocci to gram-negative organisms, as well as an increase in the Nocardia species, especially in the south of India. So Prajna et al. Did the study and they found there was a high prevalence of Nocardia endophthalmitis. However, they failed to find a solution for the same. So the microbiology of endophthalmitis in India is different from the ones reported in the EVS as well as the ESCRS studies. And latest studies have also shown that the irrigating solutions used intraoperatively were found to be the most common source of endophthalmitis. So use of amikacin in BSS could be an option when nocardia endophthalmitis is predominant. So amikacin, as we all know, it has good activity against gram-negative bacilli, against Acinetobacter as well as Pseudomonas, and it has got very good activity against nocardia and some Mycobacterium species. So what about the safety? So with this particular dose of amikacin, it was reported to have no endothelial toxicity or no macular toxicity, as evidenced on specular microscopy as well as OCT macula. And coming on to cost effectivity, 1 vial of amikacin cost only 35 rupees. So 1 vial of amikacin can be used for 20 bottles of BSS. Therefore, in a community eye care section, it becomes very cost effective. So conclusion, this is the first and the largest single center study to report comparative analysis of different endophthalmic prophylactic measures in a community eye care setup with high incidence of nocardia endophthalmitis. Introduction of amikacin in BSS is thus a unique, cost-effective and efficient prophylactic measure to prevent nocardia endophthalmitis. These are my references. Thank you.
Thank you. Thank you so much.
Thank you, sir.
Good presentation. Thank you, sir. Now Dr. Suraj Singh is on the way. Once he comes, he has to inform. Other person is Dr. Karthik. Karthik, yeah, please. And after Dr. Karthik, Dr. Ahmed. And then if Dr. Suraj Singh comes, he will also be taken if he comes before 9:50.
Good morning, everyone. My topic is on telemedicine and neuro-ophthalmology. Telehealth is the use of technologies for long-distance clinical care, health-related education, public health and health administration. Telemedicine is a subset of telehealth which delivers remote patient care through two-way communication between the patient and healthcare provider through telecommunication technology. The revolution in information technology has made a positive impact in medical field where accessibility is a major problem. Many of the trained ophthalmologists are based in urban areas, catering to just 10 to 15% of population requiring such services. Majority of our population, 80%, resides in rural areas which have very little or no access to tertiary eye care. Teleophthalmology is a techno-savvy method where medical facility is taken to rural and remote areas by using computers, video conferencing and internet. It was very useful during COVID-19 which warranted social distancing. Vision centers provide primary eye care services with the help of trained ophthalmic technician at an affordable cost. It is connected with the base hospital through internet services to enable direct patient consultation and interaction with the ophthalmologist. Eye care services are accessible and affordable by reducing travel cost and time for the patients. And patients who need further evaluation and treatment at specialty services are referred to the base hospital. So neuro-ophthalmology involves diagnosis of vision-threatening and potentially life-threatening diseases where delay in diagnosis or treatment can be devastating. Teleophthalmology helps in picking up patients who need urgent and timely intervention. We aim to study the effectiveness of telemedicine in neuro-ophthalmology. It was a retrospective observational study. We analyzed data of patients referred from 13 primary vision centers in rural areas to neuro-ophthalmology services at Aravind Eye Hospital, Coimbatore over 18 months from January 21 to June 2022. Clinical and demographic profile, diagnosis, time between referral and reaching base hospital were analyzed. Total of 335 patients were referred from vision centers to base hospital. Out of them, 88% reached the base hospital and 71% needed neuro-ophthalmic management. 59% of them were males, and the major diagnoses were cranial nerve palsy, which was maximum, followed by cerebrovascular accident, papillary edema, optic neuritis, non-arthritic anterior ischemic optic neuropathy, ocular myasthenia, and traumatic optic neuropathy. Other diagnoses were primary optic atrophy, secondary optic atrophy, nutritional optic disc failure, and toxic optic neuropathy. And majority of patients, around 50% of them, reached base hospital within 1 to 3 days of referral. And the main presenting complaints were defective vision, double vision, drooping of lids, field defect, headache, and eye pain. The clinical findings based on which patients were referred were extraocular movement restriction, ptosis, pupil abnormalities, and disc abnormalities like disc edema or disc failure. Among 65 patients who presented with cranial nerve palsies, maximum were 6 nerve palsy, followed by 3rd, 4th nerve palsy, lower motor neuron facial nerve palsy, and multiple cranial nerve palsies. Out of 27 patients who presented with CVA, 20 patients presented with field defect, 5 with cortical blindness, and 2 with vertical gaze palsy. Out of 46 patients who presented with sudden onset defective vision and RAPD, 15 patients had optic neuritis. 20 patients presenting with headache, transient obscuration of vision, and bilateral disc edema had papillary edema, and 2 patients had intracranial space occupying lesion, and 10 patients presenting with drooping of eyelids and or intermittent double vision were diagnosed to have ocular myasthenia. Toxic optic neuropathy was found in 8 patients, out of which 4 were tobacco alcohol induced and 4 were ethambutol induced optic neuropathy. All of them were evaluated and treated accordingly. Heather Moss et al. Study surveyed 135 practicing neuro-ophthalmologists in US, comparing the telehealth utilization during pre-COVID, early pandemic, and 1 year later. 1 year into the pandemic, neuro-ophthalmologists still maintain telemedicine utilization at rates higher than pre-pandemic levels. They found confrontation, visual fields, ocular alignment, and pupil examination were not suitable for teleconsultation, but it improved access to care, continuity of care to the patient. Telemedicine has been proven to be cost-effective, accurate, and reliable method for screening and monitoring in patients with ROP and diabetic retinopathy. Teleneuro-ophthalmology can be used for follow-up of into idiopathic intracranial hypertension, migraine, optic neuritis, and anterior ischemic optic neuropathy after initial evaluation and treatment.
Today I'll be talking about SmartScope Kit, which is a portable eye hospital for screening and outreach camps. I'm Dr. Hirika Gosalia, a postgraduate resident from a tertiary eye care center, catering to a large population, giving high quality service at an affordable rate, by which we conduct outreach camps. We go to outreach camps wherein we are not able to use the conventional instruments, which is quite bulky and can lead to damage during the travel. So in the outreach camps that we go, we mainly screen cataract patients. So here you can see how I'm going to the outreach camp, and we go to most patients with old patients with cataract, and we screen their anterior segment with the torchlight and the posterior segment with the direct ophthalmoscope, and then we refer them to the base hospital. So the problem here was that this was not sufficient to screen many other pathologies, and that's when we came up with the SmartScope kit, which is a comprehensive ophthalmic kit which can do all the necessity investigations. So for visual acuity, we use the smartphone-based free download, which is the eye handbook, by which we can do visual acuity tests, Amsler's grid, color vision. We use the pinhole, we put the pinhole, occluder, and the trial frame. We can also carry along the trial set. Then for anterior investigations of the systemic illness mainly, we use the BP machine, the SpO2, the torch for examination. Then we use many of the investigations required for the corneal pathologies and the orbital with syringing. And for the anterior segment, we use many innovative devices. We use the iVerter, which we use for eversion of the lids, especially for foreign body removal. We use the ASPI, which is the anterior segment photography with intraocular lens, wherein we use the which was a great alternative to the slit lamp to examine anterior segment pathologies. So we take a cardboard, we punch the hole, and then we place a 15 diopter intraocular lens at the hole, which is very good for magnifying and giving great resolution to image anterior segment images, which we put on the smartphone. And these were findings that we found at the outreach camps, ranging from corneal findings to cataract findings to neovascular glaucoma to Terigem, and you can see how the resolution and the magnification is. Then we use Shiot's tonometry for measuring the intraocular pressure. We later use we screen the patients for narrow angles, and then we use the ASPE gonio with 8 diopter lens to check the angle of the anterior chamber. Then we heap 4 intraocular lenses of 30 diopters upon each other, which created the IOL scope, which was an alternative to the compound microscope, to screen patients with ulcers to detect fungal hyphae, and we also diagnosed a screened sheep botfly larvae with a patient with foreign body sensation. And we used the Scooby-Doo, which is a smartphone aided cobalt blue filter alternative, wherein we attached a blue filter and the 15 diopter lens to screen many of the corneal findings with dry eye, epithelial edema, epithelial defect, filamentary keratitis, and many other corneal pathologies. And these were all the anterior segment devices that we used. Posterior segment, we used the trash to treasure red cam, wherein we used a sanitizer bottle, and at the edge we cut a round circle wherein we attached a 20 diopter lens. Then on the other side we attached the adapter along with the phone, and this on the other side then we put it on the patient's eye of pathology to record many of the posterior segment findings. So the results were, we found 83% of cataract patient, and next was retina patients, mainly diabetic retinopathy patients, then corneal findings, glaucoma findings. Others were orbit and neurophthal findings. So in cataract, we mostly found the immature cataracts ranging around 720 patients, mature cataracts. So mainly this was between 4,721 patients conducted across camps across Tamil Nadu, Karnataka and Kerala. And in orbit, chalazion was most found. In neurophthal, most found was optic neuropathy. In retina, diabetic retinopathy, macular hole was found. So out of the 4,741 patients across 26 camps, we found around around 800 patients were referred to the main center, and there is some issue. 800 patients were referred to the base camp, out of which 200 were received treatment in the cataract section, and out of the patients in the non-cataract, which were the corneal and orbit findings, we referred patients of around 195, and around 85 were treated at the base hospital. So all I'm trying to say is that SmartScope kit is a great alternative to the existing system, and we can screen many segments from the anterior to the posterior segments. One second, just give me 2 minutes. So coming to results, so out of 4,471 patients, cataract patients were 1,220 patients, and out of which around 700 were referred to the base center for cataract surgery, and out of that non-cataract patient 195 were asked to go to the base hospital, and around 95 were received treatment. So SmartScope kit was a great alternative, ASPE being an alternative to the slit lamp, IOL scope being an alternative to the compound microscope, Scooby-Doo being the alternative to the cobalt blue filter, and the trash to treasure red cam being an alternative to the fundus photography, which is the normal indirect ophthalmoscope. So I would like to ask everybody to use the SmartScope kit to screen, to not miss any diagnosis and to avoid misdiagnosis. Thank you. No, we as residents have tried to use it. Whoever goes, we try to capture images, and we discuss if we need referrals, if we are in doubt. So it's a new initiative. We use innovative tools. It's not been used earlier, but right now, since the study we have started, we are using it for all camps. Yes. Only one, ma'am. We were just attaching. Yes, yeah, ma'am. Yes. Not Fevicol, ma'am. It's just a tape, ma'am. It's. Yes, ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am. No, ma'am. So accordingly, we are not using all the devices for all patients. We'll use it according to the patient's complaints. So if the patient is coming with a poor visual, yes, ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am. It was adding up to around 7 to 10 minutes more.
Very innovative projects. I think next time you should present it in the innovation section.
Yes, ma'am. Yes, ma'am. Thank you.
Dr. Ruhail, I think you are aware that your membership hasn't been ratified and you will be marked. However, please present.
One sec. Good morning, everyone. I'm Dr. Ruel. I'm a resident, and I'll be talking to you today about the influence of revised RNTCP guidelines on the prevalence of ethambutol optic neuropathy. I have no financial disclosures. As we all know, tuberculosis is a huge burden in India, and in 2019 alone, India reported 2.5 million cases of active tuberculosis in that 1 year. So the RNTCP, to eliminate TB, came up with the NTB strategy, and one of their protocols, one of the changes was to change the protocol of treatment of TB itself, and this came out in 2016. So in this revised guideline, the intensive phase was only, the ethambutol was given not only for the intensive phase, but also for the continuous phase. And from not only from three times a week, it was changed to a daily regimen. So we hypothesized that this longer duration of ethambutol given would have a greater chance of developing ethambutol optic neuropathy. And our aim was to document this influence of the revised RNTPC guidelines on the prevalence of ethambutol optic neuropathy in a hospital-based setting. So ours was a multicentric retrospective descriptive study of new patients at the neuro-ophthalmology clinic at a tertiary eye care center in Tamil Nadu, in 3 sub-centers, Madurai, Coimbatore and Tirunelveli, between Jan 2017 to August 2022. We included all new cases of ethambutol optic neuropathy that were diagnosed during this period. And those cases where there was a diagnostic dilemma, where the duration of ATT was not clear, were excluded. So we searched the electronic medical records for all cases with the history of taking ATT or were on it during this period in the 3 centers. And we got a total of 2,832 cases with a history of taking ATT. The same electronic medical records were searched for new cases of ethambutol optic neuropathy during this time among the 3 centers. And we recorded a total of 212 cases of new ethambutol optic neuropathy, as well as 41, out of which 41 cases came for a follow-up for at least 4 months after stoppage of ethambutol. So we calculate prevalence in each year by the number of new cases diagnosed with ethambutol optic neuropathy divided by the number of cases that had a history of taking ATT or were on it in that year. So we analyzed the age, the gender, the comorbidities of the patients, the duration of exposure of ATT, as well as the visual acuity, both presenting and final. And these were our results. The overall prevalence increased from 1.6 to almost 3 times to 5.49% in 2000 from 2018 to 2019, and it further increased in 2020, only to fall back in 2021, which we attribute to the effect of COVID-19. Most of our affected individuals were males, and they were between the age group 31 to 70 years. They were equally divided between this age group. Diabetes and hypertension was the predominant comorbidity in almost half our patients. And ATT exposure was around 6 months. The mean ATT exposure of most of our patients before presenting with ethambutol optic neuropathy was around 6 months, with even 1 month of ethambutol even after 1 month, and even at the max 23 months presenting as well. And there was an average delay between time to diagnosis over 2 months. So patients were sitting at home with these symptoms for around 2 months. As you can see in this graph, only 8% of patients presented with ethambutol optic neuropathy within the 2 months, of which was the traditional protocol. Around the rest 92% of cases presented in the extended spectrum of ethambutol being given. Visual acuity of most of our patients was 6/60, and the final vision was only 6/30 in those that came for follow-up. When we compared initial vision to the follow-up vision, we found that a better initial vision at presentation was predictive of a better visual acuity, and those who presented with lower visions like 1/60 had a worse follow-up visual acuity. In this Kaplan-Meier survival curve, we compared time after ATT and the chance that they would improve after stopping ethambutol. And we found that after 6 months of ATT, there was a very low probability of visual improvement after stoppage of ethambutol. And those patients who were exposed to at least 6 months had a very low prognosis of improvement. I'd like to conclude by saying there was an increase in prevalence of ethambutol optic neuropathy, and duration of AT is highly associated, but this might not be the only factor. There's an avoidable delay to diagnosis of around 2 months, and this plays a role of awareness among patients. Ethambutol optic neuropathy may not be completely reversible, as we can be seen by the final vision outcomes, and improvement of vision may depend on the presenting vision. Our limitations was, it was a hospital-based study and cannot be applied to the community, and secondly, COVID-19 really affected our data collection. As a take-home point, there must be an increased awareness among all healthcare providers who are treating tuberculosis, and every patient must be educated on the possible side effects of ethambutol to avoid delay in diagnosis. These are my references, and I'd like to thank my mentors, Dr. Siddharth and Dr. Padmavati.
Dr. Rajesh Subhash Joshi.
Good morning, everyone. Can I have my slides, please? Yeah, I will be talking to you, all of you, on novel method to screen patients for glaucoma by translead tonometry. This is basically a community-based project. This was developed in collaboration with the Vishveshwaraya National Institute of Technology, so I acknowledge all the engineers there. As you know, approximately 11.2 million persons aged 40 years and above have glaucoma in India. Many people go blind undetected. Therefore, there is necessity to screen patients for glaucoma at large. In the light of existing manpower and resource constraints, we evaluate options for screening glaucoma. The only modifiable risk factor for glaucoma is intraocular pressure. There are various methods which are available for the measurement of the IOP, and the applanation tonometry by handheld or by slit lamp mounted is the basic one and the most appropriate one and gold standard. So the drawback of the applanation tonometry is you need to indent the cornea, the cost which is involved, and the physician need for the measurement of the intraocular pressure. So we have developed this device without compromising on the quality. The working principle of this method is the Imbert-Frick principle. When you apply pressure on the sphere, the volume inside the sphere is equivalent to the pressure which is applied and the surface area. The same principle being used. This was the experimental device which was developed. It has a cylinder with plunger and a pressure sensor. The plunger has a circular plate of approximately 3.06 mm. The tip of the plunger was placed over the closed lid. This is the experiment which we perform. It has a cylinder and you can see it is pressed over the closed lid, and the cylinder has a sensor which was carrying the signal to the indicator either in the form of red or green. It was adjusted to 20 mm of Hg. If the pressure was more than 20 mm, it was red, and if it is less than 20, it was green. So the initial device which was developed was cumbersome and with lot of wires, but it was detecting the intraocular pressure either less than 20 or more than 20. So there was lack of digital reading. So we developed the finite element model, and the 3D analysis of the same thing was done. So, but there was a problem of lid pressure. When we indent the lid, there is always a problem of lid indentation. So that was also taken into consideration. When we indent the lid, the pressure which is exerted by the lid is around 4.1 mm, which was adjusted to the sensor. So the device was modified to this one, which was giving the digital reading also, and the changed sensor, which was high sensitive pressure transducer, was introduced. The testing of the device was done at the Tertiary Eye Care Center with ethical approval from the hospital. A single observer which was proficient in taking intraocular pressure by applanation was considered, and he measured with applanation method as well as with the new device. The initial reading was with the new device. After interval of 15 millimeter, after interval of 15 minutes, IOP with applanation was taken, and 3 readings were taken, and the mean of 3 reading was considered. Assignment was consecutive, and the patients coming to the OPD. Exclusion criteria were patients with corneal opacity, operated case of glaucoma, lid abnormalities. Those who underwent refractive surgeries were excluded. Data was compiled and filled into the Excel sheet. So this was the area which was needed to be indented. When we close the lid, there is elevation which is there, and this area need to be indented. And this was with the device. The device had a plunger which was of 3 mm size, and the area of the plunger was 3.06 mm. So it was giving the digital reading also. The cleaning of the device you can do with the sodium hypochlorite or with the saline also. The statistical methods which were applied were Mann-Whitney test, regression analysis between 2 groups, Pearson's correlation, and the sensitivity and the specificity of the device was also done. The total eyes which were screened were 956. This shows the mean age, number of males and females, and with applanation method, it was 14.18 mm. The range was 7 to 48 mm, and with the new device, it was 10 to 15. Range was 10 to 15.8 mm of mercury. So there was not much of difference. This was the coefficient of correlation between the 2 devices. It was almost correlating, and the sensitivity of the device was 90%, shows that it is able to detect positive glaucoma subject 90% accurately, and the specificity of the device was 88%. The advantage of the device is portable, simple for health workers in rural areas, a simple method to measure IOP, no need of ophthalmologist. If patient wants to measure IOP at home, but he need to teach about the things. The screening of the patient in camps and rural areas, and no need of local anesthesia and fluorescence. The limitation of the device is we are in process of fitting camera on the plunger, so that we will come to know the exact position of where it is indented, and multi-center studies which are required. So the conclusion of my study is that detailed statistical analysis showed no significant difference between the IOP measured by the applanation and the tonometer. And it is an excellent device, zero contact with cornea or influence of corneal biomechanics on IOP results, provides best way for rapid screening of this patient in the community settings. Thank you.
Dr. Rajesh, are you aware that such a device is available commercially in the market?
In fact, there is a transscleral device which is available. We need to place it over the superior aspect of the limbus, and that measures the intraocular
If you
pressure.
get a chance, visit the Mediscience Devices stall. I think they have one which measures over
Yeah,
there.
it is a transscleral one.
So have you ever tried remote thermometer?
No, sir.
Because remote thermometer is a very simple device. It's we are using for last so many years. It is comparable accumulation, the readings are comparable with accumulation, and it's there's no need to anesthetize the eye, and even we can use it in the child also.
the duration needed is very short, and it will come in market shortly. Yeah, for home care. Yeah. Yeah. Thank you.
So, good morning, respected judges and friends. I am going to present my paper on digital revolution in glaucoma screening, now offline on a smartphone. These are my financial disclosures. Sir, sir, it's not moving, sir. So, Dr. Venkatesh, me, and Dr. Kavita do not have any financial disclosures. Dr. Divya Rao works for Remedio. She's a medical director over there. So, as we all know, previously undetected glaucoma levels, according to the prevalence studies, show that the vast majority of glaucoma in less developed nations are undetected, and about from 50% of that is advanced disease, and 20% of them are blind. So, there is a need to screen. There is a need to have a device which screens faster. So, using this offline on-the-edge AI integrated on a smartphone fundus camera, it generates a referral report in 10 seconds. It can be used at any time, any place, whether it is a remote camp where there is no internet or electricity. It can be used in vision centers and also at home. And it can be used by anyone, whether it is a MLOP, optometrist, or general ophthalmologist. And this AI generates a report, and it just does not give vertical CD ratio, but it also highlights areas of concern. As you can see in the picture, it shows, it highlights the RNFL defects also. So the purpose of our study was to assess the performance of this novel automated screening tool for reference.